Good morning, everyone. I welcome to all, and it is my proud privilege to coordinate this session of gynecological oncology and to be a co-convener with Dr. Anu Patni ma'am, as she is my guide and mentor during my fellowship program. And I'm very thankful to Dr. Jasuja sir for giving me this opportunity to coordinate this session in the international conference. Now I invite Dr. Anu Patni ma'am for the welcome address and introduction of this conference. Welcome, ma'am.
Good morning, everyone. Hello, Megha. We are only few people, so let us at least. Yeah, so attendance is scarce, but anyway, we will go ahead and start the program. I first of all would like to thank Dr. Jasuja and his team for organizing such a comprehensive gynae onco session in this prestigious 6th International Breast Cancer Conference. And I would also like to welcome you all to spare your time to be here on this Sunday morning for this session on gynae oncology. Well, I will like to take this opportunity to take you through the gynae oncology journey till date that we have encountered and the world has encountered. Let us just spare a few minutes for this. As we all know, knowledge of gynecology with additional training or experience in gynecological cancers and expertise in detecting and treating females of reproductive system is gyne-oncology. And the authorization for certification for special qualification in this field was approved by American Board of Medical Specialties only in March 1973. So it's a relatively new specialty. The Society of Gyne-Oncology was established in 1960. First scientific meeting was held in 1970, January. GOG, the Gyne-Oncology group that we all follow, was founded in 1970. And in India, the Association of Gyne-Oncologists of India was registered on 16th December 1991 with Dr. Kasturi Lal as the founder president. FIGO became in charge of internationally providing staging for various gynae malignancies in 1976. And now in clinical practice, FIGO staging has practically replaced the TNM classification. We follow these staging criteria currently. And a few landmark findings I would like to mention here. As far as cancer cervix is concerned, HPV, the virus, and the vaccine. I think they are the best inventions about cancer cervix in this century, and these two gentlemen were awarded Nobel Prize for the same. WHO in 2019 came up with a global strategy towards eliminating cervical cancer as a public health problem, which is again a landmark in gyne-oncology. But there are a lot of things to move forward to, like single-dose vaccine, therapeutic vaccine, cost-effective customized screening, management as per new staging, no MIS for early stage till another trial proves its efficacy, fertility-sparing cancer survivorship, and maybe upfront targeted therapy later on. Now, as far as endometrial carcinoma is concerned, earlier it was considered as the simplest of all, and now I think it is the most complex of all, as we will see in the coming lectures. And sentinel node, a lot of inventions have been made in the treatment of endometrial carcinomas. Sentinel node has found its definite place, and now the molecular classification is confusing all our minds, and it is the way forward here. But we also have to find effective management of comorbidities, management strategies in obese patients, improving fertility sparing treatments, skill development in MIS, and targeted therapies. Ovary is the most mysterious of all organs, and it can say I, the ovary, possess a mysterious physiology that affects all from head to toe. It's for a vigilant clinician to decide whether she or he wants me as a friend or a foe. And targeted therapies and receptor studies have become the norm in ovarian cancer, but we have to look forward to prevention, screening tools, diagnostic tools, and more to come in receptor studies and targeted therapies. Well, as far as Association of Gyne-Oncologists of India is concerned, it now has 1,437 members, which is a considerable number. Separate departments are there in various institutions with MCH, DNBs, fellowships, etc. And MCI has made MD/MS in Gyne and OBS a prerequisite for Gyne-Onco practice. The journey in Rajasthan has been a little turbulent. When I started my practice in gyne-oncology in 2000, people and practitioners both used to say, "Welcome, ma'am. Ma'am, please aage aa jaiye." People and practitioners both used to say, "What is gyne-oncology?" By 2005, the question was, why do we need a separate branch? By 2013, they acknowledged it as a separate branch, but they said we can do without a specialist. A lot of consistent and persistent efforts made us gain attention to the need of gyne-oncology by 2019, and we formed a consolidated state chapter of Association of Gynae-Oncologists of India. By 2020, opinions were sought from gynae-oncologists for female genital cancers. And 2021, the first fellowship started in gynae-oncology at Mahatma Gandhi University of Medical Sciences and Technology. State chapter was launched in 2019 under the by Dr. Sudhir Bhandari, the then principal of SMS Medical College. And this is the team of founder pillars of Association of State Chapter of Association of Gynae-Oncologists of India. COVID took its toll and we were not very active for 2 years, but we did our share of webinars alone and with other societies. And after COVID waned off, public awareness programs. So this was the milestone. The first medical university was Mahatma Gandhi Hospital and Medical College for starting fellowship in gynae-oncology at Sri Ram Cancer Center. I had the privilege to be the first trainer and mentor of these two fellows. Both my fellows are here today. Dr. Shagun Gupta, Dr. Chandrakanta Sulania, please acknowledge them. They will take gynae-oncology to another level in the state. So just to mention, holistic gynae-oncology services include prevention, screening, management of pre-malignant lesions, multimodality management of all gynae malignancies, and follow-up and palliative care. All of these we are practicing in the form of customized diagnostic procedures like colposcopy-directed biopsies, office endometrial biopsies, hysteroscopy-guided biopsies, therapeutic procedures for pre-malignant and carefully selected early malignant lesions like LEAP, like cone, like trachelectomies, simple and radical, surgical procedures for all invasive cancers like radical hysterectomies, like staging laparotomies, like cytoreductive surgeries for ovarian primary cytoreduction and interval cytoreduction, and extensive cytoreductive surgeries for ovarian carcinomas like radical vulvectomies, sentinel node biopsies for vulva as well as endometrium. So this is a multimodality management like in all specialties, and especially oncology. We do need the help of our radiation oncology, medical oncology, surgical oncology colleagues, and interventional radiology and palliative oncology have become an indispensable part now of oncology. At our center, we have good diagnostic facilities from basics to advanced diagnostic facilities, excellent oncopathology facilities with histology, with IHC, with receptor studies, you name it, and whatnot. And gynae-oncology doesn't stop here. There are a lot of special services that we need to provide, like genetic counseling, like cancers in young females, like fertility preservation, cancer in pregnancy, ovarian conservation, cancer survivorship, quality of life issues, and so on and so forth. So I sincerely believe it is very important that an oncogynecologist is directly involved in the management of these patients before, during, and after surgery to improve the outcome of these patients and give them a holistic approach. And I also hope that Rajasthan establishes more and more of specialized centers to improve the gynae-oncology health in the state, because you get what you focus on. So focus on what you want, and gynae-oncology is the way forward. All the best to us and to all of you for this specialty. Thank you so much. I welcome you all once again to this gynae-onco session, and I will now call Dr. Chandrakanta to conduct the session further.
Now again, I invite Dr. Anu Patni ma'am, and for the topic, she speaks on the molecular classification of recent developments in recurrent or advanced endometrial cancer. Dr. Anu Patni ma'am, please.
यही वाला recent developments. Yeah. So here I am again. Actually, I would have loved to give this talk after Dr. Somshekhar's talk, because he was to give the basic concepts on molecular classification, but he's busy in the other session. So I will first speak on recent developments in advanced and recurrent endometrial cancer. Like I said earlier, endometrial cancer was supposed to be a very simple and best to have gynae malignancy, but it is not so now. And the recently released data by ICMR shows that the incidence of cancer, 1 in 9, is there a pointer here? Yeah. Yeah. So 1 in 9 people in India are likely to develop cancer in their lifetime, which is a good number, too good a number, I would say. And 1 in 190 are at risk of developing uterine cancer, out of which 80 to 90% are endometrial cancers. If you look at the cancer trends in India, incidence of these cancers are on a rise: breast, uterus, ovary, lung, and prostate. Cervix, esophagus, stomach, and hypopharynx are decreasing. So uterine cancer is again increasing. Just to give a background, globally, the incidence of endometrial cancer has increased by 0.69% per year between 1990 and 2019. In patients with advanced and recurrent distant disease, overall 5-year survival rate is only 17% as per American Cancer Society. And endometrial cancer risk stratification based on histological type, grade, and stage, which we have been following till now, is seen to be quite inconsistent and imprecise, leading to over and under treatment many times. So molecular classification has now come in, but still there are a lot of confusions regarding this and its integration into the management, but we will try to talk about it. Dr. Somshekhar would have talked about the molecular classification. I will just elaborate the names. It is highly reproducible and with good prognostic value. And this uses basically 4 molecular subtypes, namely Pol mutant, MMR deficient, P53 aberrant, and NSMP, which is no specific molecular profile with normal or wild type P53. And WHO recommends integration of molecular parameters in all pathology reports now. So this basically, you can see here, these are the low-grade endometrioid carcinomas. This is currently applicable only to type 1 or endometrioid carcinomas of the endometrium. And these are the high-grade carcinomas. And here the inner circle is showing the molecular classification. So copy number high and MSI high are included in the high-grade endometrioid carcinomas, whereas MSI and copy number low are in the low-grade cancers. And these are the molecular pathways which lead to the expression of molecular indicators. Now, for the purpose of management, NCCN uses the following categories for delineating endometrioid cancer treatment groups. These are disease limited to the uterus, suspected or gross cervical involvement, and suspected extrauterine disease. So if you talk about uterus confined disease, this includes stage 1A, stage 1B, and stage 2. If you talk about extrauterine disease, this includes 3A, 3B, 3C, and 4A and 4B. 4B is mainly individualized management, but up to 3 and 4A is blanketed in advanced stage endometrial carcinoma. So this is a busy slide, like all NCCN slides. They do give, I will take you to the flow chart. I think this will be easier for everyone to see. So if it is a surgically staged stage 3 and stage 4 endometrial carcinoma, you can individualize the treatment. In stage 3A, systemic therapy and or EBRT plus minus vaginal brachy. 3B, systemic therapy and or EBRT plus vaginal brachytherapy, because here vagina and parametrium are involved. 3C1, pelvic node positive. 3C2, para-aortic node positive. Systemic therapy is preferred with or without EBRT or with or without vaginal brachy. In 4A and B, if it is completely debulked disease with no residual disease or microscopic abdominal disease, then we can go ahead with systemic therapy plus minus EBRT plus minus vaginal brachytherapy. If it is 4B with residual disease or even 3 with residual disease, treatment would just be more or less palliative, especially in 4B. So these are, just to complete the list, these are the type 2 or serous carcinoma, clear cell carcinoma and carcinosarcoma, where in stage 1A, you can either observe or give systemic therapy with or without RT. In rest all stages, chemotherapy with or without RT. But these are not included in the endometrioid NCCN. Now, PORTEC-3 was a landmark trial on adjuvant chemoradiotherapy versus radiotherapy alone in women with high-risk endometrial cancer. And the patterns of recurrence and post-hoc survival analysis were studied in a randomized phase 3 trial. And PORTEC showed that the radiotherapy, the chemoradiotherapy arm resulted in better overall survival and failure-free survival in all patients and in patients with stage 3. See, this is the blue line is the chemoradiation, which is better survival overall and failure-free survival in stage 3. So here they established the definite role of chemotherapy along with radiotherapy in advanced stage endometrial cancer. Also similar were the results for serous cancers. If you look here, the recurrences, because what we are concerned with in management is to define what would be the pattern of and the incidence of recurrences to decide on the prognosis for the patient. So basically, if you look at the number of vaginal recurrences, they were equal in both chemoradiotherapy and radiotherapy arm, but the other recurrences, the pelvic recurrences, the distant recurrences, and total number of recurrences were much less in the chemoradiation arm as compared to the only radiation arm. Hence, the chemotherapy was said to be an integral part of management of advanced. Almost 11% improvement in overall survival was seen with chemoradiation, with the addition of chemotherapy in stage 3 disease. This is another trial which has recently published its data, GOG 258. Now, they studied adjuvant chemotherapy plus radiation versus only chemotherapy. In the chemoradiation versus only chemotherapy in advanced stage endometrial cancer. And they found that there was no difference in relapse-free survival with only chemotherapy versus chemoradiation. So maybe only chemotherapy will become the future norm for advanced stage endometrial cancer. We do not know yet about it, not in the guidelines yet, but yes, maybe a thing of the future. As you can see here, almost the similar results, chemoradiation, better results with only chemotherapy in some of the cases. Now, overall numbers are almost same. I don't think this slide is visible from far, but recurrences, overall numbers are almost same with chemotherapy versus chemoradiation. So these are the NCCN chemotherapy recommendations for recurrent metastatic or high-risk endometrial cancers. Actually, all studies that are, most of the studies that are done, they take as an umbrella metastatic as well as recurrent disease. So the overall recommendation is that multi-agent chemotherapy regimens, out of these, carboplatin paclitaxel is the most preferred one as of now. I think my medical oncology colleagues will can tell us better about these studies and these findings. And if you use single agent, cisplatin is the one that is the most used. So as far as surgical management of advanced stage of CA endometrium is concerned, treatment is individualized based mainly on disease extent at presentation and patient's performance status. And in future, we will incorporate molecular profiling into this. Surgery is often the mainstay of treatment till stage 3 disease. And as far as adjuvant radiation is concerned, all patients with positive pelvic nodes will receive pelvic radiation. All patients with para-aortic and common iliac node involvement will require additional extended field radiation. Adequacy of surgery has a bearing on outcomes, and abdominal failures in stage 3 have again prompted evaluation of WAR. WAR is whole abdominal radiation. Earlier on, it was used but was dropped because of a lot of toxicity issues. Again, this has come into studies. Now it is being studied because a lot of abdominal failures were seen in stage 3 after treatment. As far as I just mentioned this here for the future. Molecular analysis of POTEC3 suggests that MMR deficient endometrial cancer may have an increased sensitivity to radiation. So again, molecular profiling might be a guide as to what specialty to use for future. And in advanced MSI high endometrial cancer, improved progression-free survival was seen with chemoradiation versus only chemotherapy. So in this group of patients, maybe chemoradiation will be better as compared to only chemotherapy as seen in GOG 258. So we might see certain changes in the future. Now, this I have already told you that POTEC3 showed superiority of chemoradiation to radiation alone, and GOG 258 concluded that chemoradiation was not associated with longer relapse-free survival than chemotherapy alone in stage 3 and 4A. These are the various trials that were done. This was GOG 258, which showed the non-inferiority of chemotherapy alone. Now, as far as there are certain cases where we have to give radiotherapy alone, which is when patient is unfit for surgery or disease is too advanced for surgical debulking. Total dose of radiotherapy alone is similar to that for carcinoma cervix, but a larger tumor-directed dose is given to the uterine cavity. The Walt application along with external beam radiation, and overall 5-year survival rate is no more than 45 to 60%. NCCN has also given certain recommendations in its principles of pathology, and it says that estrogen receptor testing is recommended in the settings of stage 3 and 4 and recurrent disease. Always when a recurrent endometrial carcinoma comes, please again test for estrogen and progesterone receptors on that tissue. Also, you can consider HER2 IHC testing in TP53 aberrant endometrial cancer regardless of histotyping. Hormone therapy is also given in disseminated metastatic or recurrent disease. Progesterone is the first line therapy. Tamoxifen and other SERMs are an option. Aromatase inhibitors and tamoxifen form the second line or second preferred hormone therapy. Medroxyprogesterone acetate, megestrol acetate are the most commonly used, and tamoxifen can also be given for a few months, although response rates of up to 33% are seen, but for short duration only. So now this is POTEC4A trial, which is now an international randomized trial of molecular profile based adjuvant treatment for women with high risk endometrial cancer. This is ongoing. We will see the results in 2023, and this is the schema that they are following. In all stages, they are doing molecular profiling also and correlating with the adjuvant treatment. We will see which is best for which molecular profile in future. Now, like I said, most trials have included recurrence along with metastatic disease, but there are some basic concepts that we must know about recurrence. So 80% of recurrences happen in first 3 years, and about 50% of patients have locoregional disease, 25% present with distant recurrence, and remaining 25% can have both local and distant recurrence. Several studies showed a relapse-free survival of 60 to 70% after complete debulking and adjuvant radiation. So complete surgical treatment and proper adjuvant treatment are very, very important. Median 5-year survival of 55% is seen after pelvic recurrence in most studies, and only 17% after distant metastasis. These are the, as you can see, with increasing stage, the incidence of recurrences increases, and also the histology has a bearing on the type 1 or the endometrioid have less recurrences, but as you go towards serous, clear cell and other cancers, recurrences increase. So these are the recurrences after chemoradiotherapy and radiotherapy alone. This I think I've already told you. Again, NCCN guidelines, we will just go through a flow chart for this. Now, I will just highlight here, when we face vaginal vault recurrence in a previously irradiated patient, we must go for a surgical resection if it is feasible, followed by adjuvant local RT. If the patient is not irradiated previously, we can directly give her an radiotherapy. And but local control with radiotherapy is worse for larger tumors. If the tumors are more than 2 centimeters, you can go for EBRT plus brachy. And but still, I think the local control will depend on the tumor size a lot. Now, there are certain innovations in radiotherapy also, like for vaginal recurrence. Now they give EBRT with elective nodal radiation and brachy boost. MRI-guided brachytherapy has come in to better give a guided radiation, and laparoscopic guidance is being now used for applicator placement, for more precise placement of applicators. When there is locoregional and abdominal recurrence, the norm earlier as far as surgery was concerned was pelvic exentration with curative intent. But there has to be an isolated pelvic adenocarcinoma recurrence after radiotherapy for pelvic exentration. 5-year survival rates after pelvic exentration in various studies were reported to be 56 to 70% with R0 resection. But if the resection is R1 or R2, which is there in most cases because of various factors, then the 5-year survival is only 20%. So to give a 5-year survival of 20%, this procedure is too morbid a procedure for the patient. So we must do justice when we do go for pelvic exentrations. Now, surgical cytoreduction is coming more and more in vogue and replacing pelvic exentration because this is less morbid alternative. Retrospective studies have demonstrated feasibility and additional value. We need more prospective studies. Solitary recurrence, tumor size less than 6 centimeter, and performance status were found to be favorable factors in various studies. And no gross residual disease, as always, and negative margins improved overall survival. Neoadjuvant chemotherapy followed by debulking has not been studied so far, but may be considered in individual patients. Further research is needed. Again, for pelvic recurrence, EBRT with the boost, like I said, RT plus CTs or surgery on individualized basis has to be done. Re-radiation is a challenging issue due to toxicity, but is now better with image-guided procedures and stereotactic radiation therapy or MR-LINAC. Stereo-guided radiotherapy is also suitable for oligometastatic disease, which is less than 5 total lesions. Then you call it oligometastatic disease. If there is a solitary distant metastasis, there is limited literature. Case reports of solitary splenic, pulmonary, hepatic, and cerebral met resection are available. Favorable prognostic factors were, again, good performance status, long disease-free interval, and clear margins. These are the newer modalities, SBRT, cone beam CT, and MR-Linac. My radiation oncology colleagues will know better about these. As far as chemotherapy is concerned, GOG 209 has confirmed non-inferiority of carboplatin paclitaxel as compared to TAP regime, which was used earlier but had a lot of cardiotoxicity and other issues. So overall, the response rates of 30 to 35% were seen in women with advanced or recurrent endometrial cancer with various chemotherapy regimens. These are the various trials that were done here. This is the one which proved the non-inferiority of paclitaxel plus carboplatin. Now, newer treatment options are immunotherapy, hormone therapy, and targeted therapy. Various selected targeted pathways are being used. Trastuzumab was used but not yet approved. Selected anti-angiogenic mechanisms were studied, and even bevacizumab was used in some trials but not yet approved. These are the various cytotoxic. These are the hormonal agents which were studied in various studies, anti-angiogenic agents which were studied. These are the emerging targeted therapies. Temsirolimus was used, but again, it is not yet approved. Just 2 minutes. This is an overall chart of how to deal with metastatic disease. You do or recurrent disease, you do an immunohistochemical analysis. If it's an ER/PR positive, then you go for hormone therapy. Again, like I said, progestins and tamoxifen or aromatase inhibitors. If it is MMR deficient or MSH high, then immunotherapy is preferred. Now, the pembrolizumab is approved by FDA, and this combination of livatinib and pembrolizumab is also approved by FDA, and this can also be given in MMR proficient patients. Now, other profile, if there is a profile other than this, then you go for paclitaxel carboplatin chemotherapy. So take-home message is multidisciplinary and collaborative efforts are needed for best outcomes in these complex cases. Gynae oncosurgeon should be an integral part of the team, and thorough counseling and holistic support should be given to all patients. Thank you so much for your kind attention. I would be happy to take any questions if there.
Thank you, ma'am, for so much elaborative talk on the recurrent endometrial cancer. Now, as sir has come, so who to invite? Okay. Now I invite Dr. Vineet Talwar. He is Director and Department of Medical Oncology, Rajiv Gandhi Cancer Institute, Delhi. Sir will speak on first-line maintenance carcinoma ovary, role of PARP inhibitors. Over to you, sir.
Pointer, right? Okay, fine. This one. Thank you, madam, and I thank the organizers for giving me this opportunity to talk on a topic which is a hot topic nowadays, that is the maintenance therapy. As all of you know, that the mainstay of treatment in carcinoma ovary is surgery and chemotherapy. Lately, you had the targeted drugs, but now you have immunotherapy and you have the state-of-the-art PARP inhibitors which are there, which come into the treatment paradigms. So why is the PARP inhibitor more important? Because if you see, you give chemotherapy or you add the biologicals with it, you are just looking at 1 to 1.5 years. So invariably, whether you give chemo or you give chemo plus targeted therapy, invariably you find that about 70% of ladies relapse within the first 3 years of treatment. And if you look at the 5-year-old overall survival, it is a dismal 35 to 38%. So there's a significant need for better frontline treatment to improve the outcomes for women with ovarian cancer. Another fact is that when you look at the first line, second line, third line, now we have a plethora of choices for the treatment. What is happening is there is a shrinkage when you go from the first line to the second line, third line, fourth line, fifth line. So from about 28 months of median progression-free survival, you're just having a 4-month progression-free survival. So the accent here is to stretch the first line treatment or to give a maintenance so that this gets stretched and you have the sensitive clones still which are there in the body which might respond to the subsequent treatments. So is there any strategy by which you can stretch this? Because when you see the survival, you find that this graph keeps on dipping as the time goes. So that is the reason why we choose for certain strategies by which we can embark on stretching this first line. And how is it done? This is either you give the conventional platinum doublet, which is paclitaxel and platinums. It can be carboplatin or cisplatin, but generally we are giving paclitaxel and carboplatin. Or what you do is you give a PARP inhibitor maintenance, or what has been conventionally followed now, you give a BEV maintenance. Or the latest is you give a combination of both. So that is what I'm going to delve on. So we'll be focusing on this maintenance, because if we stretch the this period, so that is the only way by which we are going to do justice to the treatment. So the US FDA approved PARP inhibitors in ovarian cancer are, you have a whole gamut. You have olaparib, you have rucaparib, you have niraparib, and then you have talazoparib, and a lot of paribs are coming and joining the bandwagon. So I'll just go through the whole schema. So the schema of my talk will be to see these 4 trials in which olaparib is being used, olaparib plus bevacizumab is being used. That is, you are having a PARP inhibitor and along with that, a combination of a VEGF, whether it is beneficial, or you're using niraparib or you're using rucaparib. So you have 4 main drugs which I would be discussing. So, just to recapitulate, if you talk of the, if you make a pie chart as to what is the percentage of patients in ovarian cancer who would come under the ambit of treatment of PARP inhibitors, you have the BRCA1 and BRCA2 mutants. So BRCA1 is the commonest, that conforms to about 15% of all the mutations. BRCA2 you add another 5%, so you have about 15 to 20% patients who are BRCA mutant. So this was the thought process which was there about 5 years back. Now we know that there is another subset which is the HRD, that is the homologous recombinant deficient cancer patients. Now these patients, they conform to yet another 30%. So you have the BRCA group and you have the HRD group. So if you talk of patients who can come under the ambit of treatment for PARP inhibitors, it is about 20 plus 30, that is about 50%. So with these PARP inhibitors, you can target 50% of the patients in the maintenance, whether it is the first line maintenance or it is the second line maintenance. So to make life simple, solo trial is in those patients in first line maintenance who are BRCA mutated. So those patients who have BRCA mutations, that is, who conform to those 15 to 20% of cases who are BRCA1 or BRCA2 positive, these are the ones in which olaparib was pitted against placebo. This was about 5 years back. Then came the HRD, that is the homologous recombinant deficient group. So the question was whether you can add bevacizumab to those patients who have been given only PARP inhibitors. That was addressed in this trial. This is the Paola trial, in which olaparib was added with bev. And they found out the patients who had the best response, they were not the BRCA mutated, or they were not the BRCA plus HRD mutated. They were the ones who were HRD mutated patients. So it is not necessary that PARP inhibitors will work only in patients who are BRCA mutated. Patients who have HRD mutations, these patients come under the ambit of this trial. And it was found that the addition of bevacizumab to olaparib, it augmented, that is the VEGF augmented the action of the PARP inhibitors. So it was a double whammy for the cancers, and that way it proved benefit. The third one is that you have the BRCA mutated, which is solo. You have the BRCA and the HRD mutated. So there is a group which is not HRD, it is HRP, that is homologous recombinant proficient, who don't have these deleterious genes. So in that group, the niraparib drug was pitted against all the others. So in all comers, it was tried whether it is beneficial or not. So it was found out that in patients who were BRCA positive, they had the best response. In the patients who had HRD positivity, they had a slightly lesser response. And in some group of patients who were HRP, that is homologous recombinant proficient, even they had about a few months of survival benefit. So these two drugs, that is niraparib and rucaparib, these were given in all comers. So rucaparib was given in the Athena mono trial. It was given in all patients who had completed chemotherapy as first line to see whether they benefit or not. So this is the basic skeleton of my talk here. And now we can just quickly go through the trials. So I'll just repeat again. You have BRCA mutated, you have HRD. BRCA is only conforming to about 15 to 20% of the whole gamut of mutations which are seen in ovarian cancer. You see the HRD group, you add another 30%. So BRCA plus HRD is about 50% of patients whom you can target. Patients who have BRCA mutations, you can give olaparib or rucaparib or niraparib. You can give all of these because the onco driver is BRCA. So you can target the PARP inhibitors. Patients who are BRCA negative and HRD positive, in this, again, you can give olaparib and bev. This is the Paola trial. And patients who are all comers, that is, who are either BRCA mutated or non-mutated, HRD deficient or non-deficient, in that you can add Prima or the Athena mono. So this is the first trial which I was talking about, in which it was a newly diagnosed patient with stage 3 or 4 high-grade serous or endometrioid ovarian cancer. And they had undergone cytoreductive surgery, and they had either a complete response or a partial response. Mind you, patient who has a progression of disease, they cannot be taken up in the maintenance arm. So you have patients who had germline, somatic, or BRCA mutations. So this was the only subset which was there in solo trial, and they were given olaparib 300 milligrams BID versus placebo. This was a 2:1 randomization, and patient who had a complete response after 2 years, the drug was stopped. So the time limit is 2 years, or you can go on till the disease progression, or if there's any intolerance. So the primary endpoints here were progression-free survival, and the secondary endpoints were overall survival in this trial. And you find that the progression-free survival is maintained over a period of 5 years. So this is something very heartening. So what I was telling you was that, say, after first set of chemotherapy, if you can prolong the time period, that is the thing which is going to give you an actuarial survival benefit, not that you keep on jumping from one chemo to the other, to the other, to the other. So if a patient has BRCA mutation, that patient is going to have the best response. If the patient is HRD, that patient will have a slightly lesser response to PARP inhibitors. Some patients with HRP, those who don't have BRCA also and don't have HRD, they are the ones also who might come under the ambit of PARP inhibitors. So here you find that patients who were put on PARP inhibitors who are BRCA mutated, even after 5 years, 50% of patients are alive, which is something very profound, which was unthinkable earlier. So the PFS is about 48% are alive after 60 months. And, after these 7 years, you find that if you compare to the placebo, again, you have the median overall survival, which has not been reached. So such a, stark difference is there between the placebo and those patients who are given this drug. So this was the outcome. The maintenance led to a substantial unprecedented improvement in PFS. Unprecedented means you have patients who have the BRCA mutations, which are about 20% of all ovarian cancers, subjected to treatment, and you find that 50% are alive after 5 years, something which was unheard of. So that gave the clearance to this drug. And now we go to the next trial, in which you have again high-grade ovarian and serous endometrioid cancer patients who have undergone surgery, who are platinum and taxane-based surgery post that, and they might have 3 cycles of bevacizumab. So now the obvious question is, which are the patients whom you give bevacizumab? Bevacizumab you give to high-risk patients. High-risk ovarian cancer patients are the ones who are either stage 3 or who are stage 4. They are those patients in which the cytoreductive surgery has not been proper. They are those patients who have pleural effusions, who have polyserositis. And they were the ones who could be given bevacizumab along with conventional chemotherapy. Now the question arises, you continue bevacizumab after the completion of chemotherapy, you give it for about 2 years, or along with bevacizumab, you add olaparib in those patients who are HRD or BRCA positive. And in this, the primary endpoint was the progression-free survival, and the secondary endpoints were the overall survival and the toxicity indices. And here again, you find that if you see the progression-free survival, it is 22.1 months against 16 months, which is with bevacizumab. So again, I'll reiterate, patients who are BRCA positive, patients who are HRD positive, these are the patients who can be given the benefit of about 8 months, 6 months or and above bevacizumab. So you have a segment which is chemotherapy only. You have a segment which is chemo plus bev. Now you have a third segment in half of the ovarian cancer patients, because I told you BRCA and HRD conform to about 50%. So half of these patients, if you give chemotherapy plus bevacizumab plus olaparib, then you get a benefit of about 6 months over and above bevacizumab. So this was the Paula trial. And again, if you see the HRD positive patients, this was maximum benefit was in those patients who were HRD positive. So olaparib plus bev provided a clinically meaningful improvement in the overall survival also. You can see the 5-year overall survival rate is about 65% versus 48.4%. And here also the hazard ratio is very, very robust, that is 0.62. Here again, I wanted to show you, you have patients who are BRCA mutated. Obviously, they are the ones who will have the best benefit. And the patients who are HRD positive, but BRCA non-mutated. So those patients who are HRD positive, here again, you are going to have a benefit. But unfortunately, the patients who are either BRCA or HRD negative, these are the ones who are not going to have any benefit. So the takeaway message was that this was an active treatment for patients who are either BRCA or HRD, and provided a meaningful improvement in the progression-free survival, about 6 months benefit as compared to the others. So the third is the primer trial. So this is again newly diagnosed patients who were given 6 to 9 cycles. And either they had a CR, that is a complete response, or a partial response. Primary endpoint was PFS, and they were given niraparib versus placebo, and this was given for a period of 3 years, or progression of disease. And here you find that again in patients who are HRD, you have a significant improvement as compared to the placebo. So in this trial, if you can see the lowermost part, you had 30% patients who were BRCA positive. About 20% patients were HRD positive plus but BRCA negative, and 34% patients were HRP, that is homologous recombinant proficient patients. So it was found that in HRP patients also, there was some improvement as compared to the other patients. So you have BRCA mutations, definitely you find a benefit here. And if you have a BRCA mutation versus BRCA wild type, that is HRD positive, still you have improvement. But this was something which was different in homologous recombinant proficient patients. So I told you 50% patients who were BRCA and HRD, 50% were the otherwise. So even in the otherwise patients, you find that there was a slim advantage of about 1 to 1.5 months. And this is the last trial. This is the Athena mono trial. This is currently undergoing. The data is not yet approved, but one arm has been shown, that is rucaparib. That is the fourth kid on the block. And this also has shown that in all comers or HRD positive, definitely there is an improvement which is seen, as I was explaining you in the last 3 trials. So if you have the BRCA mutation, or if you have the HRD positivity, you have a stark improvement. As you can see, the curves are separating here, but you have a slim advantage in those patients who are all comers also. So I think this is the last slide. And so this is the gist of the whole thing which I've told you. So if you follow a patient from the beginning, what you do the somatic and the germline BRCA testing, plus you do the HRD testing. So initially what we used to do was we used to just look for BRCA if you go 5 years back. But now practically, for practical purposes, all patients we are doing HRD. So if you do HRD, you will not miss those 30% patients who are BRCA wild type. So you're checking for the BRCA mutation also, you're checking for the BRCA for the HRD. So by that you're capturing 50% of patients. So these patients you check at inception. Now, why do you check at inception? One, of course, it is prognostic, and secondly, it is predictive also for treatment. So if both of them are there, then it merits testing here. So initial decision should be whether you send these patients for neoadjuvant chemotherapy or you do a primary debulking. Well, if you have given neoadjuvant chemotherapy, if you've done surgery, then the next question would be, do you give bevacizumab or not post-surgery? So as I told you, patients who are high-risk ovarian cancers, these are the ones in which you can add bevacizumab after 3 cycles. And along with chemotherapy, that is paclitaxel and carboplatin, that is the current standard. So patients here, you check for the HRD, subject them to surgery earlier, or you give them chemotherapy. If you give neoadjuvant, then the decision should be for the next 3 cycles, should you add bevacizumab or not? Now you have come here, you have given bevacizumab during chemotherapy and maintenance. So whether you see whether the patient is BRCA mutated or HRD, if it is BRCA mutated or HRD, any one of them, then you can give olaparib plus bevacizumab as a maintenance, which I showed you, showed a 6 months improvement in PFS. If it is HRP, then probably you can try the Athena mono trial in which rucaparib was given, but the final testing of the pudding should be after you get the oral survival benefit. And if you have just given the patient chemotherapy for 6 cycles, you have not added bevacizumab in the anterior treatment, and the patient has not got any bevacizumab, if the patient has BRCA mutation or HRD, then according to the solo trial, you can give olaparib or rucaparib in these patients. And if the patient is HRP, I showed you there's a very slim benefit in the other 50% of patients. There probably you can discuss with the patient and give this patient niraparib, or just keep on observation, or if the patient is a high risk, you give bevacizumab. So I think that was my last slide. I thank you for your patient hearing. Any questions? Yeah. Somebody can give her a mic, please.
Sir, in routine practice, you advise both BRCA1, BRCA2 and HRD, and then give the bevacizumab with olaparib.
So you have a brand new patient. You do the BRCA and HRD. BRCA mutant, very good. You can give olaparib as maintenance. Even if it is HRD positive and BRCA wild type, you can give olaparib plus bevacizumab. So the decision of adding bevacizumab will be after the surgery. Why I'm saying after the surgery? If it is, a sandwich surgery, you give anterior chemotherapy and neoadjuvant chemotherapy. If you add bevacizumab there, then probably the surgery will get delayed, because you need a window of about 6 to 8 weeks before you can operate. These patients tend to bleed. So the best time would be you give anterior chemotherapy, you perform the surgery, and after that, if you find it is in the high risk category, which I told you, then you add bevacizumab. And after the completion of chemo, you can continue bev. If the patient is BRCA mutated or HRD positive, you can add PARP inhibitors. And when you add PARP inhibitors in that BRCA mutated patients, you find that 50% of patients are surviving after 5 years. So that is the magnitude of just taking a pill. Thank you.
Thank you very much, sir, for a nice and elaborative talk on PARP inhibitors. Now, our next speaker is Dr. Som Shekhar. He is the chairman and head of Department of Surgical Oncology, MHEPL. Fine, sir.
Thank you very much. I've kept busy yesterday, 1 session, morning session, today 3 session. But this is a very important topic. So much of controversy has erupted in molecular classification of endometrial CA. All the basic FIGO staging, what we believed, has been totally thrown out of the window. Can you ever imagine you may have a stage 2 high risk endometrial cancer just because they are pole mutated, don't need any adjuvant? It is unthinkable. Imagine that you have stage 1B, you have a tumor which is more than 50% mammary invasion, you have a FIGO grade 3 high grade. Traditionally, you would have given Wald brachy if adequately staged node negative, or EBRT with Wald brachy if nodes are not analyzed, and they would also be discussed in MDT for probable 4-paclitaxel. And now you just have to do NGS Sanger technique in a Illumina for pole, and if it is mutated, not required. Unthinkable it is what has happened, and people can't digest that. Is this really the advance that's happening? So far, all the decisions advances affected medical onco, so we're very happy. Let them scratch their brain, read and come. Surgeon, good surgery was there. Now suddenly for us also things have changed. Even, if you imagine, if you have a p53 mutation, all the patient would need chemo radiation. Then people say, do you scratch and go to paraiotic and dig everything? Either way, they know it. So first time all these advances come to the surgeon's doorstep. So you're afraid, because you need to know also update like medical oncologist. I always say fun. If medical oncologist goes for a vacation for a week, comes back, so much things have changed that 1 week they have to study to restart the practice. So this is very complicated topic. It took like weeks together for me, in spite of having attended IGCS. I was there. Then I also attended ASGO. I read a lot of these chapters, being part of panel even in IGCS New York. Very tough to analyze. I will try not to confuse you, but put in nutshell how to do it. So hopefully you will not get confused like I was, but know how to change. I bring warm regard from Aster International Institute of Oncology. It's a 4 big cancer hospital in Bangalore and over several across the world, where all multi-super specialty function is happening. Traditionally, in endometrial cancer, all we asked when I was in Mayo Clinic, when I was doing the gynae onco fellowship, we just asked size less than 2, more than 2, more than 50%, less than 50%, grade 3, story khatam. That's it. Low risk, high risk, low risk, simple hysterectomy, nothing more. High risk, do a high para-aortic lymph node dissection, laparoscopic, open, robotic, doesn't matter. And then think node negative, goes for vault and chemo, and then, node positive, EBRT and chemo. Very simple it was for us. That's it. That story was over. Then little bit, those time noises about lymphovascular space invasion was done, but it's academic, lymphovascular space and perineural, all that is just to be documented. We never changed. But things have now totally changed the way it has happened. In addition to all this, molecular classification has rapidly come, especially when Astro and Estro has also adopted them completely. So what is the current basis? If you see ESMO, ESGO, NCCN, we have low, intermediate, high intermediate, and high risk. So confusion. This is all because of POTEC trial. All radiation oncologists to blame. I hope any radiation oncologist is here. So, we love low and high. Like you do Oncotap in best, low, high, over. Intermediate, big nuisance. That's why Memoprint is better or EndoPredict is better. You make a patient spend a lot of money to know low or high. And again, you say, no, it's intermediate. So my decision is fine. Then why to spend the 2.9? Like you could have gone for a vacation, come back and made patient, save that money. This part came because of POTEC 1, 2, 3 trial, where instead of low and high, it came as low, intermediate, high risk. So much of mess available for us. Okay. So this was the current risk stratification before an era of molecular. All less than 2 centimeter, grade 1, grade 2, 1A non-muscle invasive or less than 50%, no lymphovascular low, nothing required. Surgery will cure them. If any one of them is little violative, preferably more than 50% with low factors, intermediate. High intermediate was LVSI is now positive because that was one of the very important predictor in addition to higher grade. That is high intermediate. High would be node positive or stage 2 beyond. So quite simple, you know that first you don't have to do. Second, probably we can get away with vault breaking. Third, you decide EBRT, some chemo. High, everybody needs chemo radiation. So very, very simple for us. These are all that changed. But now totally, immunohistochemistry finding. Remember, there are 4 important markers we do. P53, then, MSI, MMR, depending on you do by IHC or you want to do it by, Sanger's NGS, and then POLE. Based on this, one test cannot be done on IHC. You can do MSI and you can do P53, ER, PR, HER2, all on IHC, which is very easy. Most of the hospital have. It's few thousand rupees. Report is available in 3 days. But POLE has to be done not on IHC but on a Sanger sequence, which is NGS, which is expensive. Only there are 2 labs in India who are currently doing, which I routinely use. So now the tumor profiling has totally changed. This is the old way we studied endometrial. Type 1, type 2. Type 1, very good, obese, postmenopausal, hypertensive, diabetic, ER positive, HER2 negative, less chance of node being positive, FIGO grade 1, less than 50%, good profile. Type 2, postmenopausal, thin ladies, hormone negative, HER2 positive, node positivity very high, higher grade, needs chemo radiation, poor outcome. But all this has been now thrown off because this was the risk stratification we all studied based on Annals of Oncology published in 2016 to guide. But the problem in this was what we presumed as low risk also started recurring. What we thought at high risk, we overtreated. And there is a group of patients who don't recur in pelvis at the vault, but they fail dramatically in the peritoneum or lung, liver. So we were not able to distinguish, certain low risk in peritoneal cavity, high risk are not failing, intermediate, high intermediate are failing systemically. So we are not balancing the adjuvant chemo versus radiation. What happened is with the trend, there was a over treatment of low risk and under treatment of high risk. The most danger in onco that can happen is over treatment of low risk, applies to all breast, endometrium, gynae onco, everything, and under treatment of high risk. So what happened is people in UK used to just do hysterectomy, not touch the nodes. So you would presume that it is stage 1 and they used to give EBRT. So we over treated the low risk. If they really actually required chemo, we undertreated them. 76% of women in early risk received radiation. Imagine, it's not something easy. Spend 1 to 2 lakh rupees, 5 weeks, delayed complication, proctitis, broader problem, not justified. On the contrary, because you're not doing proper staging, you miss that node positive stage 3C, or you're not doing molecular profiling who would be P53 mutated, and chemo is more important than radiation, and they all recurred. You had one good chance to cure the tumor. In oncology, you must be damn scared when you see early cancer. When it is advanced, you say cancer is bad, jaise bhi ho, recur hone wala hai, you mess up, God is with you. But when you have early, there is no reason that lady is not cured. You must be very scared. When I see early cancer, I get scared. I sit, I discuss, because one good chance is there and we should not mess up and blame the cancer. So early cancers, don't undertreat. Same way, don't overtreat a patient which is truly early who doesn't need. So we understood that histology alone didn't decide. There is some prognostic separation that is required, which we are missing. Essentially, the whole classification changed based on this TCGA genomic atlas for endometrial CA. Those who have read, remember the signature. This is which showed POLE, MSI, copy numbers, P53. This is a landmark paper which changed everything. Remember, when you change the staging, prospectively you have to apply and find that this new changing made an impact. Retrospectively, you have to analyze and dig all thousands of cases in serial data based on this to show that the treatment changed. That's how a new figure on cervical cancer came. They introduced subclassification in cervical cancer. They found that when you use the 2 centimeter, 3 centimeter criteria size and the depth, then the treatment changed based on that. So this is how the molecular thing looked, that progression-free survival versus months. You can see that if this patient had a POLE mutation, practically all are cured. It doesn't matter their stage 2. Stage 2 means what? Cervix deep involvement present, more than 50% present, even though they are FIGO grade 3. Imagine there is one test which can separate that intermediate, high intermediate for a superb. Look, practically 100% of them have progression free. Now, if you come back to green, so if they are unstable MSI or deficient, not proficient, deficient, they suddenly drastically start having more progression. Means they lost about 20-30% of the women are dead by 5 years, followed by the type of P53 you have. So if you look back, the worst would be if you have a P53 mutation, 60%, 60 out of 100 women are dead, even though they may be 1B. So these are the two landmark things which told us, this is the TCGA genome atlas, followed by the analysis from the SEER data, which changed everything. So we knew this type 1, type 2, very easy. How to integrate now into, POLE mutation, class 1, very good. Then we have MMRRD, how to do it. Remember, MMRD, MSI is done in IHC, very easy. Few thousand, you get report in 3 days. But only POLE is something which you have to do it on, Sanger sequence. So it's not easy, costly, expensive. 2 lab do it. They charge a lot of money. So even though the current guideline US is to do that and then come down, we go lower down in India. P53 is done easily. Then, MSI, MMR is done easily. ERPR, HER2 done. So the last one, the worst of all, is P53 mutation. That would change everything. Practically, most of them would need chemotherapy and radiation. So how did we integrate this, and how the changes now happened with this particular area? A roughly screenshot I'll give you. Worst is P53. Luckily, they constitute 5 to 15% of all endometrial CA. Usually, they are high grade. Tumor infiltrating lymphocytes are there. And then they need NGS Sanger hotspot to identify. And they are the patients who are type 2, what we studied, low BMI patients. So now if you look at MSI, this is something which would be endometrial, high grade, lymphovascular space invasion. And then, they are high BMI, there could be Lynch syndrome associated. So look for that. And then if you look back for P53 mutated, they are the one who have high copy. They are the worst. Beauty is it can be identified by IHC. When you do it, at least ask your pathologist, please do ERPR, HER2, MSI, and P53 by IHC. Then decide only those patients who need POLE. Because stage 1, if they're all favorable, you don't have to do anything. Stage 1B or 2, then you can go back to POLE and see, can you avoid all this treatment? And they are the advanced disease, they onset late. Now I look back each one of them. So POLE mutation is in 10% endometrioid, relatively young woman, high tumor grade, high mutation, classified as high risk, exceptionally good prognosis. Treatment de-escalation, no RT for low stage. You can omit chemo even for higher stage, intermediate and high intermediate. So look at the recurrence-free survival with RT, with chemo RT, or with just surgery. Practically, they are same line. So this is a good thing to have if you can have, but expensive test to do. Then if you have MMRD, remember MSI, MMR are counterpart. One is by IHC, the same thing can also be checked on an NGS. So whichever you have, you can do. It's based on a molecule you have. They are sporadic. They constitute 20, about 1/3 of endometrial cancer, and they're high grade. Large number of tumor infiltrative lymphocytes are there. They respond well to RT. So don't miss radiation if it is indicated, like 1B, or it is stage 2. So it's very important. This helps us to know radiation. P53 mutation helps us to know who needs chemo, and then POLE mutated helps us to know where both can be avoided. So I'm trying to simplify it because I read about 100 paper to come at this point. So I'll put it simply, if I can't give a good message. Then, P53, now here you see the Kaplan-Meier curve. There is somebody in US FDA, we always laugh. If you have a new drug, medical oncology, what they love, the costliest drug, with small benefit, they love that. What is the benefit? 2.5 months overall survival for 50 lakh rupees. Immediately path changing, path breaking. And it's always told that you take on laser point. If we can negotiate this laser dot between the two curves, utna jagah hai, US FDA will come. Approval. So here you can see how much difference is there in between these two. They significantly benefit with chemo. So don't miss this. These are the patient, even if they are node negative, they benefit. This is the best thing you can do. And remember, the chemo for endometrium is not a very high toxic chemo like fulfiri or irinotecan, oxaliplatin. It's just a paclitaxel, which is very, very, very easily tolerated. Many times 4 cycles. GOG trial showed that 4 cycle of paclitaxel in endometrial CA is equivalent to radiation to para-aortic, because we don't want to give radiation to para-aortic. Kidney is knocked out, duodenum knocked out, bowel adhesion, intestinal obstruction. And if you extrapolate that and this data, P53, it is equivalent to para-aortic treatment, no RT to para-aortic, chemo gave a survival benefit. Look at the survival benefit that we had. Roughly 60% are alive, otherwise 20-30% only are alive. So P53 for chemo. Doesn't matter, early, advanced, please add chemo. Okay. Now, this is the part which we need to, but the beauty of this is, these are all done on IHC, which is very easy. So based on this marker, MMRD, P53, POLE, we classify now endometrial cancer into 4 varieties. If you extrapolate the PORTEC trial, what is PORTEC initially showed? It showed that if you adequately staged, node negative, EBRT plus Walt brachy is equivalent to Walt alone. So don't give unnecessary EBRT, over treatment of low risk. We are replaced now with no EBRT in endometrial, adequately staged node negative to brachy. Then it also went one step ahead and looked at it. So EBRT doesn't have overall survival benefit. Surgery and chemo has or not. Then we want to see, can chemo replace radiation? So if you study the PORTEC 1, 2, 3, beautiful. Now extrapolate PORTEC 3. They say ideally you do POLE. If it is mutated, very good. Kuch khas kuch karne ka hai nahi hai. But this in India take 40 to 60,000 rupees. Everywhere it is not available. Only 2 labs in India today to do it. So this is the right way. Then if it is wild type, then we know it is bad. Then you do MMR. Then you looked at it whether it is proficient or stable. If it is stable, you are still in good. If it is unstable, then add P53, wild type good, mutated bad, then go to chemo RT. This is nice in US, not. So we start ulta like this, and we come last, because I do P53, I do MSI, MMR, ERPR, HER2/neu. If all are stable and it is intermediate stage 2, now I don't know chemo RT to give, then last I do this. 2 labs in India do that. I sent to them, one in Bangalore, one in Surat. And they charge between 40 to 60,000 rupees. So that way, 5% of the only intermediate risk patient would need this. But ideally, if you have all, you do this, then this all can just go off. So this is what is molecular testing, which is very, very important for us to understand. So based on this, we have 4 varieties. I will not bore you. The same way how you work out, you need to look at it. Remember, most of it can be applied to clear cell and serous endometrial, even though Endometrioid variety is what we do. So to start with, it is poly, then last is P53, but these two are easily available. You can look in the other organ. So based on this, we classify into 4. Poly unmutated, MSI hypermutated, copy number low MSS, and copy number high serous-like picture where all of them are treated like stage 3 CCA ovary. Then down the line, you look at the somatic copy, histopathology, the grade, then PIK3, then KRAS, T53, and this prognosis. See, Poly, excellent. MSI, intermediate. Then if it is unstable, intermediate. And if you have P53 or high serous, like poor. So essentially playing around all this. I hope I'm not confused. I made it very, very simple. Then we arrive at this beautiful survival benefit. Look at it. Poly, followed by MMR. Then, we have the stable. The worst is P53. And we have small group unclassified because they could either be a metaplastic carcinoma or a carcinosarcomas when the things change on the either side. So this is now, whenever you do a new classification, you have to validate it to apply. So they use the PORTEC3 data. There was a 410 case, 73, 51, 131 of all, and that could extrapolate exactly what we told. Like if you do P53 mutated, 5-year only 48% alive, PFS. So which is true. Then you see that if Poly is mutated, 98% is alive, which I told no further treatment is required in intermediate, high intermediate, then MMR, and then, NSMP. So this has been, accredited and validated in this. And so we have now the new classification here. How the old ESMO, SGO, ESTRO has been incorporated. Don't get bored. It is too busy, but I have summarized. I have a last slide where I'll give 1, 2, 3, 4, 5 spoon feeding message. So don't worry about it. I'll give the slide if you want to read. So see that now. All Poly are low. You have a high intermediate where you have MMR deficient and they're stage 2. Then you have high risk when P53 is incorporated with this, and then the worst one where you have P50. So essentially, this is matching this particular area for you to do. So what is the impact of new guideline? All Poly mutation, even though they're stage 2, low risk, no chemo, no radiation. All P53 abnormal, high risk, irrespective of node positive, negative or not. Then if these two are not there, then you have MMR RD and then the stage which is incorporated for you to do this. So this is essentially the treatment algorithm which I told. So if it is P53 needs chemo radiation both, then if it is P53 not mutated and then Poly not mutated, then only you use DMMR, then no chemo, only radiation. Remember, this is an indicator of radiation. P53 indication for chemo, Poly to avoid everything. So then here you can take RT and hormone therapy. So this is a beautiful treatment, which is called as a rainbow umbrella of what I spoke, everything. And this has been now incorporated in ESGO risk published in 2020, what I exactly told. So the old low, intermediate, high has been totally incorporated. If P53 is there, all fall into high risk. And then if Poly is there, all fall into low. Then if neither of them are there, then these two you can use MMR deficient. This has been acknowledged and published just now. Lancet 2022 called as a PROMISE 2 trial. Exactly what I told, the algorithm to be done. So how a DNA is extracted, next generation is done, and microsatellite stability. So you can go back and read this paper published, how this particular changed to do the testing. So when do you do Poly? Actually, if you have stage 2 or intermediate and high intermediate, you're not sure whether can you avoid chemo RT, that is where you do Poly. That is the group. If P53 is mutated, this has no role, they need chemo radiation. Okay, so this is the algorithm which has been given, published in April 2022, both BAGP and BGCS guideline, which I told. So in summary, Poly is excellent. Intermediate group, you don't know chemo RT to give, please do this. PORTEC trial showed that adjuvant for intermediate high risk when Poly is not mutated, P53 is not mutated, you can use MMRD. So this testing should be carried out in all non-low risk, which is stage 1 high risk and stage 2 to do that. And then finally, this is the final algorithm we arrive at to reach the best to worst survival to triage. And please read this recommendation, which is published. So Astro is adapted this very well. where to give radiation, where not to give. And then this is the latest publication which has come to follow this. So I will concise in the last slide. See, stage 3, stage 4, no issue, because they're all high risk. They're either node positive, peritoneal disease, and they need chemoradiation. Stage 1, initially we thought all stage 1 surgery don't need anything, or at the most vault brachy. Now no longer so. I will tell you. If there is no LVSI, pole is mutated, stage 1A, grade 1 to 3, no treatment. Only brachy if there are high risk factors, like more than 50%, but MMR should be negative, LVSI should be negative, and this is brachy. If the patient has 1A with myometrial invasion, grade 1 to 3, but P53 is abnormal, then they need EBRT and chemo, even though they are stage 1. So see how this thing got added up. So no under treating stage 1. Now, if you have stage 2, this is where you must do pole. If it is mutated, for all grades, for all histopathology, observation. How often? Stage 1B, then coming to 2. This is where it has changed. External beam radiation only, no chemo, if it is not pole, but it is, MMR deficient. Then extended radiation and chemo if they are P53 in stage 2. So how much de-escalation in stage 2 happened? Escalation in stage 1 happened based on this. Stage 3B all need this. So the decision now is no longer simple, no pole positive, no negative, robotic done, laparoscopy done, parietic looked, not looked, less than 2. Almost one day will come, people will forget those morphological values. So decision is totally based on this certification on molecular marking. So you must have what is there available by IHC, please do it to save the cost. Then come back to pole in intermediate stage and appropriate chemo and radiation to them. Thank you very much. I think all clear now. Thanks.
Thank you very much, sir, for this fantastic talk. Now, after this talk, I invite Dr. Aditya Murli for panel discussion, Management of Advanced Ovarian Cancer. Dr. Aditya Murli is a consultant medical and hemato-oncologist, Aster Hospital, Bangalore. Welcome, sir.
And I would like to invite our panelists, Dr. Ankur Punya, sir, Dr. Deepak Shukla, Dr. Ankit Agarwal, sir, Dr. Som Shekhar, sir, if he can join us. That's good.
Please.
Dr. Reenu ma'am है क्या यहाँ पे?
Good morning. Can I request Dr. Som also to come, please? So, taking the show forward on the Aster brand value for now, skipping quickly from ovarian cancer from endometrial cancer to ovarian cancer, and truly taking forward the ethos that if a medical oncologist goes for leave for 8 days, he has to read for 8 days before doing it. I was on a leave for 8 days, and Dr. Som made sure I read for 8 days before I came for this. But all said and done, let's do a quick panel discussion on ovarian cancer. We all heard what Dr. Vineet Talwar said, and his talk was quite clear in terms of the trials we have, the guidelines we have, and how to take it. But how do we put it in day-to-day clinic for us? And more importantly, in a setting wherein resources are not that plenty, in a resource challenge setting, how do we put it for our patients? So this is something which many of us would probably see in our clinic any day. A mid-50s lady, non-specific complaints for 3 to 4 months, reasonably fit, no medical comorbidities. Somebody does an ultrasound abdomen outside, and everybody knows this blood test called CA125. So everybody does this test. So there is gross ascites, adnexal lesion, CA125, 65. So let's probably start with Dr. Som. Sir, biopsy in all, or are you okay with cytology?
Means all the patient who on imaging looks to be neoplastic, and if my decision is surgery, then I would not do any of them. I straight away go, because in oncology there are places where you can operate definitely without biopsy. One is ovarian, then pancreatic, renal. Now, if my decision for whatever reason, patient factor, tumor factor, disease burden, or I'm not very sure whether it's ovarian or it's from GI, then I need a proof. I always try, prefer a biopsy. But however, if we don't have a omental disease, because biopsy is not from a pelvic ovarian mass, even though it's advanced, I don't like rupturing it. If a omental or peritoneal CT guided or ultrasound core can be done, that is my first preference. It's unambiguous. If I can't get in spite of whatever it is, then cytology by centrifugation, sediment, cell block is what I would prefer as a second option. Because reactive mesothelial cells and malignant cells is very difficult for people to do it. I've burned my finger many times thinking it is ovarian CA, they've given chemo, not responded well. Then when I go back, it is a primary from appendix or stomach or this one. So biopsy, if it is can be done from upper abdomen by eye intervention radiologist. If I can't get, cytology is the only thing I prefer, then cytology, full aspiration, centrifuge, sediment, cell block is what I prefer.
Dr. Deepak, Dr. Ankur, any thoughts on this, please?
Just a question. Is in a young patient if abdominal box is in means differential diagnosis, I think routinely we do a cytology and biopsy before moving to even surgery whenever it is possible. Is that
not always, because most of the time, if there is a extensive cytology, ascites and nodules, before a definitive surgery, I always do a staging laparoscopy to know optimal cytoreduction can be achieved. So there is a first trocar entry with 5 millimeter, and that would roughly give an option. I understand if the patient is saying there is a fertility issue, then I would do a staging laparoscopy, biopsy frozen, then proceed. But they're very small set of patients actually.
Dr. Jitendra, please.
Means in addition, I personally do CA also. So CA 125 to CA.
Oh, I mean, that's a part of this thing. So I mean, that's definitely a part. Dr. Jitendra, would you want to do? I mean, onco CTs are there, PET CTs are there. I'm sure in Jaipur, in place where you practice, you would have access to both. What are you okay with? What is your go-to default imaging here?
I'm Dr. Ankit.
Sorry, Dr. Ankit.
Yes, no problem. Okay, so we are very comfortable with CT scans. Once we get a biopsy done, then only we go ahead with the CT staging. PET CT routinely we are not using it in our institute. We are very comfortable with CT scans.
Fantastic, sir. I'm sorry I didn't catch your name. Dr. Ankur. Dr. Ankur, any thoughts on this?
Yeah, by default we do CT scan only for all the patients. We did abdomen and chest.
So, so trying to take forward what Dr. Vineet Talwar said initially, I mean, we have moved to an era wherein we would want all of these three informations, with a germline BRCA, a somatic BRCA, and a HRD. Has anyone tried to do a HRD testing on a cytology cell block, and have any of you felt that no, it's probably insufficient, and I might need to go back in for a biopsy? Sir, please, Dr. Somsekhar.
So definitely. Most of the time I wait for the surgical specimen to be available. But in my experience, in the limited times when I've tried, it has failed more often in cell block for HRD testing.
So if you are going to wait till you get the surgical specimen, in that interim first 2-3 months of neoadjuvant chemotherapy, would you still do a blood germline BRCA?
Yeah, I'll do.
Okay, great.
See, the ideal scenario for us in a given woman would be to do a somatic BRCA first. That would encompass both germline BRCA in that woman plus somatic. So if you do just germline, we pick up 15%. If you do somatic, we add 7% more. If you do HRD, we pick up 40% more. But in India, whether we like it or not, germline is available across the counter. Lowest cost somatic doesn't do everybody. And even if you do somatic, it is positive, then germline required for the family to do it. So ideal sequence is somatic first, and then germline, and then HRD. HRD is such a very expensive and quality dependent test. I would really like a tissue to be done. And second thing is, if I'm going to operate upfront, I get all this information after a specimen. If I'm going to give neoadjuvant chemo, for a chemo per se, whether patient is germline, somatic, or HRD doesn't matter. And all ovarian CA by law will need surgery. After 3, still I will have a disease, tissue, unless they are complete responders who are less than 11%. But I would make an attempt. That's why if we go back to my first thing, I told you I prefer a omental or a peritoneal biopsy rather than cytology. Very tough to do HRD and somatic by any lab based on cytology, even though it is not that it cannot be done. There was a paper from Tata Cancer Hospital, the incidence of able to retrieve somatic BRCA and HRD on cytology cell block, and they were successful. But it's, if I remember, 40 to 45% was the incidence. If you don't have anything, you end up with a complete response when you operate, then go back and try to do with that rather than not. But in ovarian CA, complete response is luckily very low. For us, bad for patient.
I think well put. So to sort of briefly summarize this particular discussion, cytology is more or less okay for us in our own resource constraint setting. Imaging wise is not too big a deal. Whatever we have access to is good enough for us. In an ideal world, we would want HRD and somatic BRCA also, but definitely germline BRCA if you are just treating on a cytology. Upfront surgery versus neoadjuvant. So I think the master is here, sir. Briefly on that.
First of all, it's a misnomer. Just because we are surgically not trained, we don't know how to do cytoreduction, bad quality of surgery, and afraid to do a surgery, we don't have expertise. Please don't send them to neoadjuvant chemo. There is no evidence today neoadjuvant chemo is superior to upfront surgery. I'll put it this way. Medical oncologists love to put it the other way around, that neoadjuvant chemo surgery or surgery to her not change. No, it is not same. I'll give you one example. In all the trial, 3 randomized controlled trial, MRC trial, Scorpio trial, then Ignash, Vargot's EVA-TC trial, all the trials, if you look back, upfront when you operate, the optimal cytoreduction rates were 30%. We know that the only people who benefit, survival benefit is where optimal cytoreduction. Now, the moment you give neoadjuvant chemo, optimal cytoreduction rate as per the 3 randomized trial is 70 to 90%. So here we have 30% optimal cytoreduction and survival. Chemo, 90% optimal survival. And what should be the survival? Should be better. No, it is same as this. Which means chemo and cytoreduction optimal is not same as upfront optimal cytoreduction. The reason is you develop chemo-resistant disease. Disease response, instead of solid mass, it makes a plaque. When you operate, you under-evaluate. You think everything looks fine. THBSO, intracogometomage, forced peritoneal stripping. So inadequacy of surgery, less radical surgery after chemo is a big evil on the patient. If a patient performance status is good, no extra abdominal disease is there, you have an expertise training to do good peritonectomy upper abdomen surgery, you must always operate. Having said that, if the patient performance is poor, or they are stage 4A, pleural cytology positive only, they're still curative. Or there is a suprachoroidal node or inguinal, still they're curative. Or performance of the patient is poor, nutrition is very poor, then only you send for NACT, but then do the same radical surgery what you would have done upfront. This is very, very important. So I would not send any patient for NACT unless patient's factor are there. Or extra abdominal disease is there, like mediastinal node, costophrenic node, or this. No intra-abdominal factors is a limiting factor to me. Don't misuse NACT because of want of your skill.
So I think that's a very fair point. So if we want to decide which patients needs neoadjuvant chemo, because let's all be clear, the most definitive treatment in ovarian cancer has to be surgery. In India, quite a few patients end up coming late. They come with huge ascites, and the ascites itself ends up making them a pure ECOG performance status. Added to that, the poor nutrition, that sort of pushes them towards neoadjuvant chemo. But then again, the sequencing has to be a MDT call. Coming back to my medical oncology colleagues, let's start with Dr. Ankit. Paclitaxel neoadjuvant, what do you use? Weekly, 3 weekly? Why?
Obviously more comfortable with 3 weekly, but patient related factors will obviously come into picture.
Sorry to interrupt, you said obviously 3 weekly. Could you please say that?
I'm only if the patient's performance status is not good, I will go for once a week. Otherwise 3 weekly is what I do.
Dr. Deepak, yeah.
So means the majority of the data is with 3 weekly paclitaxel. We know there is data for dose-dense paclitaxel, one of the Japanese trial has shown PFS benefit. But again, there have been conflicting data. So mostly if patient performance status is good, we'll go with 3 weekly. Else, if performance status is not good, weekly paclitaxel is an option.
Dr. Ankur, your take.
I prefer 3 weekly. Only patient with a poor performance status or poor nutrition, I'll start weekly, because otherwise most of the studies favor a 3 weekly and weekly are equivalent.
So interesting. So
I will add a point from surgeon. See, if you look back in advanced CA ovary, traditionally all the randomized control trial, the most important randomized Scorpio trial. Don't take the MRC trial, URTC trial and those, because they were done in an era which is 10 years back, where the surgical technique was not evolved, because most of the gynec units were obstetrics and gynec unit without gynae onco exposure, and the quality of surgery was very poor. Today, if you are running a gynae onco unit, unless you have a 76% optimal cytoreduction in CA ovary, you're not a good setup. This is a standard benchmark as per the GCIC and GOG. If you take 100 CA ovary stage 3C, 76% of the time, if your optimal cytoreduction not there, you're not good. Those trials which were done in NACT versus surgery were in an era where 11 to 12% is optimal. But Scorpio trial is done in an era by Anna Fagoti's group, or very good aggressive gynae oncosurgeon. And in that group, both the group 70% and above was the optimal cytoreduction. So if you look back, that type of surgery in the history of the ovarian cancer today, most of the patients biochemically fail by 9 to 14 months as per the trial and all the trial. And overall survival is 36 to 40 months. They're all non-HIPEC trial. We'll leave the HIPEC separately. So which means this is what it is. So today in stage 3C, biomechanical failure happens between 9 to 11 months by best surgery, best chemo. And then, OS is 36 to 40 months. But in the history of ovarian cancer human trial, there are only 2 trials which showed 100 months survival. 100, only 2 trials. Trial number 1 is a Deborah Armstrong trial where upfront surgery operated with IP chemo, not HIPEC, IP chemo, showed 100 months survival. Second one is a dose-dense weekly pacli by Japan. The dose-dense weekly pacli of Japan is not what we follow dose-dense. That's a very different regime. Interval also different, dose different. But unfortunately, that particular is not replicated by anybody. So this is one of those conditions. 2 more new trial now conclusively told both. But I personally believe because of some anti-angiogenic effect, in a young patient, good performance status, high volume of disease, if they can tolerate, you don't do any harm, even though it is not a level 1 evidence. We need more, because there are only 2 trials which showed 100 months. But today there is no level 1 evidence to give dose-dense weekly pacli as per the new trials. But having said that, most of the medical onco institution would believe that if it is a high nodal burden, retroperitoneal disease is more, young patient, no medical comorbidity, if they can tolerate, still they put it in that. And I strongly believe in that, because that helps us to follow the surgery.
And these data were prior to PARP inhibitors, actually.
No, but the thing is, the PARP inhibitors help only 20 to 20% of the patient. And most of them has to be given for 12 months. Even after this, if you add PARP inhibitor, the OS would improve. See, what I would look at is the purpose of adjuvant and good surgery is the first biochemical failure and DFS. Now, currently what happens is PARP inhibitor, in addition to this, will definitely add more and more. That's the same debate we have. Oh, why do you need to give HIPEC now? PARP inhibitors give. Why do you think that a good surgery and HIPEC plus PARP is better than normal surgery and IV chemo with PARP? They would add. That's how the science evolved. So, you can't say that tomorrow there is one more molecule that will come and we can't say it is not done. But that's why, but having said that, head upon head, it didn't help. So we can separate the PARP inhibitor group. Ultimately, 15-20% of them will be benefited. Who knows? In them, with all this, it might be better. God knows.
So I think GOG 262 also sort of answered this question. Incidentally, in this trial, about 15% of the patients. So what this trial did show was weekly is equal to 3 weekly. In terms of the side effect profile, the neuropathy is worse in weekly. The anemia is probably worse in weekly, but however, the neutropenia rates are lesser in a weekly setting. So, if we can tease out patients as to whom to pick weekly, whom to pick 3 weekly, we can do that. But this was what GOG 262 said. If the patient, and sometimes tier 2 cities or wherever it is, for whatever reason, if they are not able to take bevacizumab at all, in that subgroup, weekly Paclitaxel was associated with a longer PFS, which is about 4 months than Paclitaxel administered every 3 weekly, with a hazard of 0.6. And this is not something that we can ignore. Any thoughts
Yeah.
on this? Yeah.
So in terms of toxicity, there was a separate trial, MITO trial,
Correct, yeah.
where the dose of Paclitaxel was 60 milligram per meter square.
Yes.
So if toxicity is in concern, we can use that regimen.
We can use that regimen, exactly. Coming to so the bevacizumab now, Dr. Ankur, any patient you have used neoadjuvant bevacizumab, and any reason why you would even think of neoadjuvant bevacizumab?
I personally don't prefer if I give a neoadjuvant chemotherapy to add bevacizumab, just because of the concern with the surgery.
In any of Dr. Ankit, anything? No different. Sir, how long would you wait after if I have given your bevacizumab for whatever reasons?
See, 2-3 things. Use of neoadjuvant bevacizumab in an upfront, not recurrent. Data is limited in that particular area because you must understand that bevacizumab is a static drug. It doesn't act on tumor per se. It cuts off the blood supply. So there is a sidal agent chemo need to act on that. But having said that, patients, in spite of two cycle of neoadjuvant chemo, continue to have large volume of serosal disease like pleural effusion and ascites as one set of group where it really still should be considered. Remember, because then they keep responding. I have a lot of such patients who are referred for HIPEC. CA125 is coming down. Imaging wise, disease in the momentum is coming down, but ascites is increasing. There is one distinct set of patients, and most of the time medical oncologists perceive increasing ascites in spite of morphological biochemical response as bad, and they keep giving chemo because in ovary you can't give more than 3 chemo. 4th, 5th, 6th chemo, survival stop growing 3 if you don't operate by between 3rd and 4th. Those are set of patients where the mechanism is different. There, one patient I normally request medical onco to add bevacizumab to make the patient good. So remember why we started neoadjuvant chemo: uncontrolled ascites, cachexia, problem, tense abdomen, diaphragm gone up, liver gone up, breathless. And again, back to same for me to operate. I didn't touch one patient of the being pissed off with that. So those are selected group. I request them to give neoadjuvant bevacizumab. Drastically, ascites and pleural involvement goes down and cachexia comes down. They're fit to take anesthesia and operate. And I don't want to drain the ascites with a pigtail. They'll have implantation here, there, everywhere. If they use bevacizumab is a larger molecule, not easily excreted. It stays in the body for 6 to 8 weeks. So I request them then to integrate it by about second. See, by second chemo, if ascites proliferation is not going, please introduce bevacizumab early so that the last dose can be without bevacizumab. So I can still operate at 3rd week. Otherwise, even if you have used bevacizumab in the last, unfortunately, you have to wait 6 to 8 weeks. And in ovarian cancer, there are 2 markers. Last neoadjuvant chemo and surgery should be within 3 weeks. Surgery and first adjuvant should be within 3 weeks. If we miss these 2, for every week delay of initiating treatment later, woman loses 3 months. So I have this in my mind. So it is where we have to sit with them and plan the bevacizumab properly so I can operate. But if bevacizumab is given 6 to 8 weeks, I can't operate, which is sad.
So going on to adjuvant or maintenance bev in first line, I mean, this is also a very controversial topic, which with we have trials. We have a US FDA approval which says 15 mg per kg every 3 weekly, that for whatever it is. But in day-to-day practice, Dr. Deepak, what dose of bev do you use and how long do you use in a maintenance first line setting?
So I use personally 10 milligram per kg.
Any reason for that?
Means just we have 2 dose, 7.5 and 15. Both only in a subset have shown advantage, possibly in stage 4.
Fair enough, correct.
So, means there is no clear logic. I am afraid to go till 15 mg per kg. So 10 mg per kg, we use it in other settings also.
And how long do you use that?
1 year.
1 year. So 1 year from the start of bev. From 1 year post surgery from start of bev.
With concurrent chemotherapy.
And then subsequent. Okay. All right. Dr. Ankur, what is your practice?
Yeah, I routinely do 7.5 mg per kg because the results are more or less similar, and why to give a higher dose? So I prefer to give 7.5 and usually the same 15 cycles total. I will confirm.
Dr. Ankit, anything different?
No, nothing. I follow ICON 7. Basically, no specific reason, just cost effectiveness. Low dose, nothing else.
From point of gynae onco, I'll add something about bevacizumab. If you have done an optimal cytoreduction, bev will not add anything. No OS benefit, only PFS. So if you are not able to achieve optimal cytoreduction, it's your moral obligation to inform your medical oncologist. In spite of your best effort, you're not able to achieve it. then they have to have BEV, because then we have OS benefit in that group. Remember, the only two places BEV has in ovary benefit. One is platinum resistant CA ovary recurrent, and then adjuvant non-optimally cytoreduced. Very, very important. Number one. Number two, if you don't follow IP chemo or HIPEC, BEV really helps in that group, because if you see, there are 7 randomized control trial of intrapetal chemo with surgery in ovary with IV chemo, and all out 6 showed survival benefit with intraperitoneal, except one, which is the recent GOG. Their BEV compensated for IP. So if you are an institution, you don't follow HIPEC or BEV or IP chemo, please also think of BEV. So BEV would be useful, number one, if you had serosal disease, ascites, pleural effusion. Number two, you're not able to optimally cytoreduce. And number three, if you are not integrating some of IP therapy, BEV should be liberally used. Otherwise, in all other cases, it is not going to help. Second thing, BEV helps only to compensate bad surgery. But that is totally different than the PARP inhibitor. If you see the solo trial, even if you have done optimal cytoreduction, PARP inhibitor benefits maximum in that group. That's why the proof of pudding is that a PARP inhibitor by independently give OS benefit. BEV will not give independent OS benefit. It acts through a bad surgery. You have to understand as a surgeon very, very clearly. Second, if that patient is BRCA mutated, as per the OV HIPEC trial, they would not benefit with HIPEC. So I know upfront if they are BRCA mutated, then I'll do a good surgery, let them give chemo, and then follow it up with maintenance PARP. So as a surgeon, we need to read this to help them.
That's a brilliant point. That's a big reason why we need to do germline BRCA. Even if you have not done anything, if you have just done a cytology, it is important to have a germline BRCA, because that will help us decide whether HIPEC is needed or not. In the interest of time, moving on to Dr. Vinny did touch on this talk, but some practical day-to-day points from our medical oncologists over here. Dr. Ankit, let's start with you. Sir, patient is HRD positive. Which of these would you choose?
I am with olaparib alone. I usually don't practice olaparib with bevacizumab. No specific reason, but in my day-to-day practice, olaparib alone is what I follow as maintenance.
Dr. Deepak, your thoughts on this?
So HRD positive, BRCA negative, I'll use rucaparib. Means we don't have data for HRD positive, BRCA negative with olaparib alone.
Fantastic. So that's the point which I want to discuss. So what dose of rucaparib do you use? It's a terrible drug to use. I've used, so it's a terrible drug to use. So what dose do you use?
See, means rucaparib of late became available 6 to 8 months, but I am using 600 milligram, but somehow 300 twice daily is the dose which a patient is able to take.
So that is literally half the recommended dose. Dr. Ankur, your thoughts on this?
I agree with that. Rucaparib is not that easy to tolerate. I think almost half the patients I had to reduce dose because of significant anemia and GI toxicity. So if me, the option would be either olaparib plus bev or rucaparib. I will not use olaparib, particularly in this indication.
I think, see, so with due respect to my colleagues, a point which I would like to make over here is that first line therapies, doing off protocol treatment is still a little difficult for us. So I personally would strictly go by the Paola and the indication approval here. So olaparib with bev is sometimes I would use. A problem which I have faced of olaparib plus bev is anemia and fatigue. They sort of, so you give the olaparib dose that leads on to anemia, and bev has its fatigue along with it. So you put both of them together, 2 plus 2 becomes 5. So that is a problem which couple of my patients are struggling with. But still, olaparib alone in HRD mutant but BRCA negative, I am still a little skeptical on that, because the reason to use bev is completely different than the reason to use a PARP inhibitor. So I think there is more to be teased out in the data over there. Coming to the Athena mono, I know Dr. Vinny did touch upon this, but the important thing in this trial, and this is probably the reason why US FDA is still not approved, is that about 50% of the patients on the Athena mono needed a dose reduction, and about 10-12% had discontinuation. Mind you, these are all first line treatment patients. They have just gone through a whole load of treatment, 6 months of treatment with us, and then again they keep coming back with complaints. Patients will not be happy, and patients are happy, doctors are going to lose patients. So that's probably a big reason why I won't do that. Quickly moving on. I think I have 3 minutes. I'll skip through certain things. Dr. Somsekhar sir, this is one thing which I want to ask. Would you any reason to do NGS in ovarian cancer? Have you sent or would you ever consider sending NGS testing for ovarian cancer?
Normally, usually in the recurrent or metastatic.
Sir, why, sir? I mean, because see, all our information that we want, HRD is either going to give us or BRCA is going to give us. Anything extra that we would be looking for from NGS?
See, sometime if they are behaving like platinum refractory or resistant, some alternate pathway actually opens up, to know can lenvatinib be used, or some odd molecule really throws up in them, and then it would really sometimes helps us to know conventional treatment, because by first line, second line, 70% of them should respond. And if it is not there, I'm worried I'm missing something, and then I recommend repeat biopsy to rule out appendicular or GI or pseudomixance component, or some other mutation pathway beyond HRD, which might be beneficial for us to treat.
Any of you, Dr. Deepak, any of thoughts on this?
So I means not NGA, MSI I like to do, particularly for endometrioid histology of ovarian cancer. We know that these patients may have a possibility of adding immunotherapy in a relapse setting.
That's probably the only indication where immunotherapy was. Otherwise, all immunotherapy trials in ovarian cancer have failed to date. Yes, Dr. Ankur, you want to say something?
Would be a good option for non-serous, like low-grade serous or endometrial. They have some alternate pathway like KRAS or all. There is some data regarding use of MEK inhibitor. So there might be an option, a patient who has received 1 or 2 lines of therapy, but not for a purely high-grade serous carcinoma.
Dr. Ankit, what is your go-to drug in platinum refractory ovarian cancer? Strictly less than 4 months of PFS.
I usually prefer liposomal doxorubicin.
Single agent?
Yes. Single agent.
Any other?
I will add BEV in this bevacizumab.
So lipodox bev would be your go-to. Anybody wants to has tried trabectedine or?
No, it's not means platinum sensitive is the setting where we go for trabectedine.
Okay, Dr. Ankur, your take.
I personally don't prefer trabectedine. I think it's a little more toxic drug compared to lipo. So
giving it 24 hours is a big pain.
So I have very terrible experience of using trabectedine, so I prefer liposomal.
Sir, anything you want to say on this?
I agree. I would look at it. See, recurrent platinum, I would decide, am I ever going to do secondary cytoreduction? Secondary cytoreduction is limited to platinum sensitive or 6 months to 12 months. So I would look at whether I'm going to add on experimental basis PIPAC to that patient or not. Then quite often, if I want a rapid response, I request my medical onco to consider GEMOX regime. So that the patient drastically improve it. There is no OS benefit at that moment. OS benefit in platinum resistant is only through BEV. No trials in between. All of them has shown then toxicity profile. That's one set. If a patient is young, still well preserved, abdominal disease only, then I would request them to give GEMOX, so I can decide whether I can do PIPAC or some intraperitoneal therapy. Otherwise, pretty much between all of them, there is no other thing as long as you can add BEV. But we know that it's very important to understand currently today, I'm a PI for a study globally with Anna Fagoti and the whole group across the world for platinum resistant. Today, platinum resistant CA ovary, median survival is 11 months. Remember this with MEV or whatever it is. By 11 months, most are dead. By 15 months, nobody would be seeing it. We have enrolled them into a trial with Netherlands called PIPAC trial, where the survival went to 23 months. So it's very important that if they fulfill PIPAC, I request GEMOX. Otherwise, pretty much doesn't matter what they do.
So I had lots more to discuss, but in the interest of time, I'll just close. So this is fresh off the press. Yes, ma'am, please.
Yeah, it was a wonderful panel, Dr. Somsekhar. We all know your surgical expertise, and I have personally witnessed it. Lots of HIPEC and whatnot. As far as you said, your preference was for surgery for all cases, for upfront surgery for CA ovary in the primary setting. So I would just like to know your experience about the survival benefit. Have you actually studied upfront NSCT and upfront primary cytoreduction and seen the difference in both? Because based on Performance
Actually,
status.
you have not read my papers. I published 150 papers in CA ovary.
Yes,
If you
I know
Google,
that.
if you Google in my name today in PubMed, 300 papers are there international. Of them, 160 are dedicated to ovary. Just this year, in June, July, we presented a podium presentation of Indian HIPEC registry data for ovarian cancer. I'm a custodian of Indian HIPEC registry in India. 23 center, 2010 patients of CA ovary with HIPEC done in India, followed for 5 years. You can take your mobile, Google Somshekhar HIPEC ovary ASCO JCO paper. It is available. We looked at women in India, not my center alone. People say, I have 91% cytoreductive mortality, less than 1%. I do 2 HIPEC a week because I have patient referred across the world. So 110 HIPEC a year I do. So they say, oh, only in your center it can happen. Every gadget is there. I have. Now in this HIPEC registry, 23 centers in India, including AIMS, Tata, government setup, Kidwai. So which means patient with low socioeconomic strata, working in a government sector where ICU mechanism may not be good, with various expertise skill. In this paper, which we published, also we presented it in IGCS meet, in New York. We found that in Indian patient, if upfront cytoreduction optimal could be done in stage 3C and HIPEC, they had a better overall survival than neoadjuvant chemo interval cytoreduction. You can read that paper. It is available. It has been quoted after that in multiple publications. Based on this publication, I was invited by Vandriel to be part of OV HIPEC 2 trial. I'm the only center in entire Asia invited. So in Indian data, we have upfront, if optimal cytoreduction can be done, the survival of that was superior than interval, with no difference in mortality, but morbidity rose. Stoma rate still 2.8% only, in spite of bowel resection. You can read that. The paper is there in JCO.
Definitely, I don't deny that. But yes, every center doesn't have that kind of surgical
But this is the
expertise.
registry. Registry is from 23 centers in India, where half of them are government setups. That's why I was afraid that mortality may be 5%, morbidity may be 30%, bowel resection and stoma may be very high, leak rate may be high. See, ultimately mortality rate today in ovarian cancer should be less than 2% worldwide. If you do HIPEC, less than 4 as per the French trial. In Indian registry, it is 2.8%. So mortality is no different in India in spite of upfront. Number 2, the leak rates is still 4%, stoma rate is 2.8%. So that also we answered. We also looked at aggressive such surgery and first chemo to the medical onco. What was the delay? Because we have a Japanese trial where 3 weeks delay should not happen. 98% of the patients actually went for first adjuvant chemo within 3 weeks. These 4 parameters I looked. Then OS and DFS is different. You can read that, it is there.
Definitely. So R0 must have been a
CC0, if we can't achieve, nobody is alive. No benefit.
So that's the
But it's a very good paper. Read that. It is available cancer registry from India.
Very last thing here. This is fresh off the press because of my holiday and my enforced reading by Dr. Som. I had to read this a couple of days back. This came in JCO this week. So interestingly, PARP inhibitors, the enthusiasm in them is actually going. So ASCO came up with a guideline rapid recommendation update. In this, if you see, PARP had a recommendation. So for platinum sensitive ovary, BRCA wild type, HRD wild type, that is going to go. And recurrent and refractory platinum refractory ovarian cancer, third line and beyond, rucaparib had an approval for that. That is also going to go. So our usage of PARP inhibitors is going to get better and lot more directed in the next few next few years. Anything to say on this? Any of my colleagues here? Thank you all. I thank the organizers for this opportunity. Thank you.
Also, there is something new called as calyptics and then folate dehydrogenase in ovary, which is very big way come. Please read that USFDA had given an approval. And I am trying to start a trial on that. You give a IV fluorescence, which is a dehydrase blocker. And then based on that, you do surgery and give those medicines. In platinum resistant refractory upfront, there was a survival benefit. It's a good paper.
Thank you all the panelists, Dr. Murli. Now our next panel discussion is on forming oncofertility team. I invite Dr. Snehal. She is clinical director and fertility specialist, OVA Fertility and Women Care Titan Medical Hospital, Mumbai.
Okay.
Hello, good afternoon, everyone. I'm Dr. Snehal. I am fertility consultant. So today I am here in Onco conference, basically to make awareness about newer field which is coming in, which is the onco fertility team. And this is nowadays a urgent unmet need because of the improved cancer survivals. Nowadays, our focus of treatment is shifting from just cure to the quality of life, and that's why we are having this interesting panel here forming onco fertility team. I would like to invite my eminent panelist, Dr. Ranu Patni ma'am. She is senior consultant gynae oncology, Mahatma Gandhi Medical College, Jaipur. Then Dr. Somashekar sir, he is HOD surgical oncology, Bangalore. Dr. Garima, she is additional professor, obstetrics and gynecology department, AIMS, Jodhpur. Dr. Chandrakanta ma'am, she is assistant professor, SMS, Jaipur. Dr. Namita Kothari ma'am, she is chief consultant and fertility specialist, Asta Fertility Care, Jaipur. Dr. Neha Sethi ma'am, she is assistant professor, department of oncopathology, Jaipur. Thank you so much for being a part. I would like to go ahead in the panel. So here we will try to have most interactive session where there will be a case scenario. And as we know how generally it goes, so basically at the end, what is the aim of our discussion is how we can form a based onco fertility team, which is actually a combined unit, combined teams of the oncology, meaning oncologist as well as oncosurgeon and gynae oncosurgeons and fertility team. Of course, they contain other things like counselors, psychologists that will come across as we go in the case scenarios. And the flow is generally first there is a patient which is meeting onco team, then they will have counseling about these onco fertility or fertility preservations, then it will come to the fertility specialist, then again they will go back to the onco team for the actual treatment, and once the treatment they are cured from the cancer, again they will come back to us for the pregnancy. So that way is the complete circle, and we'll discuss the points as we go on. So this will be based on case scenarios, how we provide the counseling, what are the options we give them for the fertility preservations, and how it is practical, how it is feasible, how affordable. So that is the forming referral pathways and what are the ethical challenges. So we'll go for the first scenario. So that is a 27-year-old unmarried woman, asymptomatic, diagnosed with CIN3 on routine pap smear. Now the cancer diagnosis is adenocarcinoma stage IB1. So now we'll discuss different viewpoints. So now in the cervical cancer, what are the possible causes of fertility loss? So I think we can start with Ranu madam about enlightening about these things. So what are the possibilities of the fertility loss?
I don't think cervical cancer per se causes fertility loss. The only issue is the disease might flare up, or pregnancy is not affected by cervical cancer as such. But of course, once diagnosed, it has to be treated before you give a good outcome to the obstetric outcome, actually. But we have to consider oncological outcome also, which is the priority in any patient with malignancy in pregnancy.
Yes. Now, ma'am, in such a patient, so I would ask Dr. Chandrakanta, if now she is coming to you, it is the diagnosis, and then before planning the treatment, you want to give her the options for the fertility preservations. So what you would be counseling her?
Yeah, this is adenocarcinoma stage 1B1.
Mhm.
That is, if the tumor size is less than 2 centimeter.
Yes.
In this case, we can offer her the fertility sparing surgery. That
Yes.
is, laparoscopically, we can do radical trachelectomy.
Mhm.
And after that, because one more thing is there that even in 1B1 stage, there is chances of lymph node metastasis of approximately 15%, which is further increases at 30% in 1B2. So up to less than 2 centimeter, we can manage the patient and we can do fertility sparing surgery, and we can save the patient and
Okay.
give her parenthood.
Yes.
I would just like to add, before
Mhm.
we go for any fertility sparing surgery, we have to fulfill certain criteria.
Criterias, yes.
So she is, of course, she's an unmarried girl and would like to save fertility potential,
Mhm.
and she is in the reproductive age group.
Yes.
But apart from that, it is 1B1, so obviously 2 centimeter or less,
Mhm.
and there has to be enough margin.
Yes.
Actually, at least 1 mm margin has to be there beyond the disease for us to be able to remove it. So it has to be favorable histology as well. You cannot do it in unfavorable histology. It has
Correct.
to be either squamous or adenosquamous carcinoma. You cannot do it in rarer or ones with poorer prognosis.
Sure.
So basically, you have to fulfill the criteria for fertility sparing. And once those criteria are fulfilled, you can go ahead with a radical trachelectomy, which can be done with either route, either abdominal or vaginal.
Mhm.
And you can also do it vaginally with laparoscopic lymph node dissection, or you can do it laparoscopically. So route is immaterial. We have to
Yes.
give her good oncological and obstetric outcomes. for
Yes, and that of course will follow those criterias where she is fitting into those criterias. And next, then I would come to Dr. Garima. So, what are the options for the fertility preservation in these patient? This patient you will advise.
So basically, fertility sparing surgery, we all have discussed it.
Yes.
Besides just doing the surgery, I think it is very, very important to counsel her regarding the future fertility aspects.
Mhm.
As in, spontaneous conception rates are good,
Yes.
but then she might need to go for some ART procedures in case she doesn't conceive spontaneously. And even if she conceives spontaneously, we have to explain her the chances of having a bad obstetric outcome in terms of miscarriages and preterm labors,
Yes.
because those are known with radical trachelectomy.
Mhm.
Besides that, in case she doesn't conceive spontaneously, fertility preservation options would be to go for oocyte cryopreservation or embryo
Mhm.
cryopreservation. These two are established fertility preservation procedures.
Yes.
So if we want to go for oocyte or embryo cryopreservation, that has to be done logistically. It is better to do it after surgery, because if you do it before surgery, then chances of spreading the malignancy and technically difficult.
Yes.
So ovarian cryopreservation and embryo cryopreservation are two established procedures available. And in case if you have not done a fertility sparing surgery in a properly selected patient, and post-operatively she has those risk factors for getting an adjuvant treatment. In
Mhm.
that case, the ovaries have to be protected before the radiation is given. So ovarian transposition is one.
Okay.
So these are the options available.
Yes.
I would differ here in the sense that like she said, we have to do it after surgery. But
So
I
we'll come.
think we can go ahead.
Yes, we
before
can go
surgery,
ahead before
because
surgery,
after
yes.
that, then we would delay the adjuvant if needed, and
Yes.
we have to rule out metastasis before.
Correct.
You go ahead with
Yes.
fertility.
So I'll also
Namita,
yeah. If anything, any from fertility point of view, I was coming to that.
Actually, before advising her for fertility preservation, I think we must go in for her fertility markers, which are very important.
Correct. Yes.
Because presently we are facing lots and lots of patients of POI, that is premature ovarian insufficiency, even at the age of 25, 26.
Correct. Yes.
PCOS, in fact, has absolutely gone from the fertility. It is now POI. So before, giving her lots of hope for fertility preservation, her ovarian antral follicle count, anti-Mullerian hormone, these are the two important markers,
yes,
which are to be done. Then only we should go
we
ahead
can
with,
discuss further
yeah.
options.
Yeah.
Yes. Anything Dr. Neha wants to add?
As per a
pathologist, I just like to mention that what the margins which Ranu ma'am has
Correct.
just-
Whether it's a free of
whether it is
yes.
free or not, and we always look for the paracervical and paravaginal margins
Correct.
for it, so that you can do your procedures well on time.
Yes. So those points have been discussed. So as per pathology, so margin, it has to be free. Margin should be free. And madam has very well discussed about the fertility sparing surgeries. And of course, as you said, those fertility preservation options are to be discussed at the point of diagnosis. Even though, yes, it is difficult because it's an existential crisis for the patient. We agree that, but that's the role of the counselors and a complete team where we need to discuss those points before starting or before planning any, treatments. And as a fertility specialist, as madam rightly said, we would want to know her basic fertility potential first by doing AMH and AFC. And accordingly, we can guide her. And as she is unmarried, we can give her an option of the oocyte cryopreservation. Yes, there are other options. If the known partner, embryo cryopreservation, oocyte tissue.
What is her age? Age
is 27. Yes. So, and the ovarian tissue cryopreservation also can be done, but it is initially, it was experimental, but nowadays ASRM has removed that label and we do it. Only requirement is we should have the institutional ethical committee for that, institutional review board. So that we will discuss in further. And so of course, and later on, we'll come to it in a different cases, like later once the patient is cured, we again give her a chance for the spontaneous pregnancy. If it is there, we go ahead. If not, then definitely we come back to fertility by these options. So we'll go to the further next case. So it is a 15-year-old post-menarchal girl.
I would just like to,
yes.
Giving her chance for spontaneous pregnancy. I don't know what the other panelists think, because we don't need to waste any time in a known case of malignancy.
Yes, and it
so we can straight away go for assisted reproduction.
Definitely.
Also.
And
Yes.
then that will be all planned based on her AMH. So that is AMH and AFC.
That is
how
right.
much ovarian reserve she has, because we don't know whether she would have required any adjuvant chemo or radiation. If that is the thing, definitely we should go immediately for the ART. And based on that, as I mentioned, even suppose the uterus is maybe radiations and all that, then there are problems with the uterus. There are recurrent miscarriages or recurrent failures also. IVF failures, and also that also other options like surrogacy and other things to be discussed in such a patients. Yes, so we'll move on to the next, which is she is a 15-year-old post-menarchal girl. Diagnosis is a scleronodular Hodgkin disease, stage 2B. I know, though the session is more of the gynec onco, but here my point is, it is still, the thing is, it is only for the gynec onco cases. Onco fertility is only for that. No, actually it is for each and every cancers. Especially, and this is because we are dealing with the young patients, young adolescent age group, and hematological cancers are much more in that. And that's why I've just put this scenario. We don't want to discuss much onco point of view. Of course, the plan will be given by the oncologist, but for the gynae, for the onco fertility point of view, we just wanted to discuss how severe is the risk of damage to the fertility potential. So I think anyone can comment on this?
So basically, even if this is a non-gynae cancer,
Yes.
but I think all gynae oncologists should be aware about what all chemotherapies are most gonadotoxic. So in Hodgkin's lymphoma, we all are aware that it is cyclophosphamide-based
Correct.
chemotherapy, and this is the alkylating agents are
highly toxic.
highly
Yes.
gonadotoxic.
Yes.
So, but having said that, the cumulative dose of cyclophosphamide which is being administered is mainly going to decide how much gonadotoxicity that the patient is going to experience. So that is there. So since she is going to land up into this cyclophosphamide-based chemotherapy, it is important that with the diagnosis itself, the patient is referred to an oncofertility team, and then the fertility preservation options are discussed.
Yes, correct. Very correct. And just I would like to ask Dr. Namita. So as you said, the markers are very important because, as she said rightly, these patients also, because of the extreme catabolic stage, first of all, the reserve would be lower. So we don't know. Sometimes we have seen even the younger patients, AMH is very, very low. So in that, it is then very difficult. And ma'am, I would like to ask you and throw some light on about the counseling for such a girls, where if in case she is going for the oocyte cryopreservation, she will require ovarian stimulation and monitoring. So in that, like, and the approach for the, monitoring, whether it is a transvaginal scan, how it would be, and the approach for the oocyte pickup.
Yes, counseling we'll have to do, because
Yes.
definitely we would like to go in for a transvaginal pickup.
Hmm,
We
hmm.
would not like to
Correct.
go in for any laparoscopic or abdominal pickup.
Hmm.
So transvaginal pickup, we'll have to counsel the girl, her parents, and accordingly we'll have to start our protocols. And since we all are aware that now these random start protocols
Yes.
are not dependent on the cycle, you can start it
Anytime.
immediately.
Yes.
And you don't even in fact have to wait for the withdrawal bleeding.
Hmm.
And now we have these progesterone primed protocols, which are also very, very effective in these patients. So this is very important to counsel them. And plus it's very difficult on their part to understand also
Correct.
that how important this will be, because their main aim, because we do get referred patients at our center from the oncology department of SMS, and they hardly 1% materialize.
Correct.
So
Correct.
that is something, because their immediate concern is the survival of
Exactly.
the girl rather than
So-
this. So counseling is a very, very important part.
Correct. That's why that is a very practical problem. Basically, we are facing.
Actually, I would like to know from Namita, because I think in her case, she's a 15-year-old girl. The ovarian reserve will also be less, than it's a highly catabolic state. Then
Yes.
then it's a chemotoxic regime that she has to be given. So, what do you do before cryopreservation, or what are the procedures that can be followed for such a
Actually,
small girl?
Ovarian tissue cryopreservation should be done, but then this is a big challenge, because in India, I think 1 or 2 centers are
Yes.
doing it. And what is the outcome? Because all over the world, I think we have 82 to 83 documented
Yes. Only
childbirths. Yeah.
those documentations.
After
More it is,
ovarian
yeah.
tissue cryopreservation. So we do get patients, and we have some oncosurgeons also inquiring from us that are you doing ovarian tissue cryopreservation?
So this is still in a research basically.
process.
We need to
and-
work on it more and more.
Yes.
Yes.
So the only thing is that we will have to do her AMH, antral follicle count, give her a minimal stimulation of 9 to 12 days, and go in for oocyte vitrification. And then she
Yeah.
can go in. For
That is
her-
the current practical basically
yes.
approach that we can, but more and more, because this oncofertility, I mean, it started almost like 10-15 years more in the Canada first, and they started their consortium and all those things. So I think there is a need, because they have a dedicated centers, they have a dedicated team, so there they can do it. So I think there is a need now to form such a combined units, and there should be the guidelines which are
And
which we have
also,
to follow.
the
And
embryologist is a very important
yes, very important part of this team.
because there is difference between cryopreservation of oocytes
And the
ovarian
tissue. Yes.
Ovarian
Very
tissue
true.
is slow freezing, which is
Yes.
updated.
Yeah.
Oocyte vitrification is rapid.
Rapid, ultra rapid
Therefore,
freezing.
embryologist is a very, very important part of this.
Yes, and later on there are the different techniques, like what we are going to do while we are using that tissue. Either there is a transposition, but sometimes in the hematological cancer we need to first find it out whether there is a metastasis.
Because I don't think in
Yeah.
her case transposition is
not,
going
not
to help.
transposition, sorry, transplantation. I mean, I just missed the word. Orthotopic transplantation, where we are going to transplant the tissue again, but there are risks of the reseeding of the cancer cells, so that we have to rule out. And another things, again, we have like in vitro activation of the oocytes and in vitro maturation of the oocytes, but those techniques are in research, so we have to work on it more. Here, I put this case again for one more reason, so to discuss about what are the challenges in dealing with the pediatric cancer populations, because these are the major our patients which we are going to face. So here, basically, as I had mentioned, so these patients have basically experimental fertility preservation options, that is either tissue oocyte, the ovarian tissue cryopreservation or testicular tissue for the males. So they require an institutional institutional review board approval. And basically children and adolescents, they lack the capacity to envision a future in which they want the children, but in adulthood regret a decision that not pursuing a fertility preservation when offered. So it is a very, very complicated and awkward situation.
I think we
So-
should have a legal person also in the team.
So we will discuss even the legal and ethical consideration of it. And there are ethical concerns when parents are making their generational decisions for their children, which is again an ethical concerns. But basically, what are the required things are informed consent of the parents, which is very important. And here, of course, it should be very clearly mentioned. And from the oncologist point of view also, when the oncofertility counseling has been given, the documentation is very important, that such a counseling, these options were given, what patient and the parents they have agreed upon. If they have denied, yes, to be mentioned, and at least there has to be a counseling by the team, fertility team, as well as the counselors. And especially in the pediatric age group, we have a pediatric counselors which are there. So they will first make them understand what exactly is about the knowledge about the reproductive system, and then going forward. So definitely these are few points for the parental consent.
And the second last point, that fertility will be ensured in adulthood
Yes.
by preservation.
That is not
also
essential.
not there.
This
Yes.
negative counseling we will have to
Have to
explain.
do
them.
correct,
Very
because
important.
yes, sometimes it is something that definitely 100% it will happen. It may not be, because it all depends upon how the cancer treatment goes, how is the prognosis, how is the cure, and later on what are actual conditions of the patient. So that is also there. And sometimes they think in a little different way, okay, fertility is going to be preserved, so this is going to be very good cancer outcome. I mean, that is also not there. So all those things. And
besides
yes,
fertility, there are so many other challenges also in this population. Like
yes,
one needs to worry about her puberty transition,
correct, yes,
menstrual health, sexual health, her psychological status. So many more challenges are
other
associated.
things are also there, yes, that we have to so that's why the documentation and the consent from the child, that is also very important. And as I said, there are certain points where ethical reviews are required. I'll not go much into detail, but this is just to understand the workflow, and that is very important. So whenever the patient presents, the important is to provide the counseling by the primary team, and whether they have they want to go ahead, then yes, that consenting, and then sometimes the video consenting is also been done, and then the patients are referred to the fertility team. When the patients are pre-pubertal, in a male we have a tissue preservation testicular, in a female we have a ovarian tissue. These are the options, but those are experimental. Then pubertal, in a male it is easier, sperm freezing, but sometimes if it is azoospermia or any other problem, then testicular freezing. And in female it is oocyte cryopreservation, embryo, or ovarian tissue. And even if patient has denied, we have to accordingly document.
Another problem with OTC is that when you transplant these ovaries back, you need to counsel that 50% of the ovarian reserve is going to get lost by the time the ovary is establishing the vascularity. So that thing also need to be, informed
Yes.
beforehand.
Yes, absolutely
Yes.
right. Because that is why AMH and antral follicle count
it
is very,
matters.
very important documentation.
Yes, that is very important. And again, while they are starting a phase of the treatment, that time also, and from the beginning also. So that counseling, I think, at every point of time, and realistic picture in front of the patient and the family, that is very important.
Counseling has to be modified according to her clinical picture and
Correct.
the circumstances.
Yes, yes. And
To individualize it, right?
yes,
Very true. Very true.
yes, that also will come to it, key financial aspect. So I think we'll go to the next scenario. A 23-year-old man. This is for the male. I have just taken.
I think
For
we should have taken a medical oncologist in the panel.
Yeah, one medical oncologist for this. But this is just to cover all aspects basically. So and the diagnosis is AML. So again, I think yes, Dr. Chandrakanta, if you want to add on.
Yeah. AML is an in onco emergency.
Yes,
So we
correct.
have to start
Yeah.
treatment as early as possible. The options available are the TESE,
Mhm.
testicular sperm extraction. This
Yes.
will be the best, and so as soon as we can start the treatment.
Yes. So first is a semen preservation, because I think Dr. Namita would.
Yeah, semen.
Semen preservation. Ma'am, you want to add on?
Yeah, these if sometime See, semen preservation by masturbation. This is the
Yes.
best option.
Hmm.
We have young, students who are studying in LN and all. They're competing for their career exams, and suddenly they are, diagnosed by this malignancy, and so they're being sent to us. So due to stress, they actually sometimes cannot produce. the
Yes,
semen.
that is a practical
So,
problem
yeah,
again.
so
Yes.
in these cases, we can do a testicular
Testing.
sperm extraction. That option is there.
Yes. Okay, so we'll not go much in detail. So we have the option, very simple, is the semen preservation if it is there, or otherwise TESE or OncoTESE, micro-TESE. Then this is another interesting case where 32 years, nullipara, there is a mass in the left breast, 3 centimeter irregular. There is a family history. So maternal grandmother is having pancreatic cancer, maternal aunt is having postmenopausal breast cancer, maternal uncle had melanoma. And the cancer diagnosis, so there was on biopsy invasive ductal breast carcinoma and ER positive 95%, PR positive 95%, and HER2 and U positive, and no notes. So I think I'll will start with Dr. Neha for this case.
Okay, as you can see, the patient is having multiple, the genetic history is also there. And
Yes.
so we will go for the genetic testing first.
Correct. Yes.
Most commonly BRCA1, BRCA2 and other genetic mutations are there. And as per the diagnosis part, we always do a true cut biopsy and put the hormones as well as HER2 to categorize them as per the their molecular subtyping, so that likewise the oncologist and surgeon will plan their treatment.
Correct. So here the point was importance of the genetic counselor and the genetic testing, and also fertility point of view. I'll ask Dr. Namita to put a light on it. What are the special precautions we take during the ovarian stimulation, because it is now hormone sensitive
Yes.
tumor. Yes.
So during ovarian stimulation, as we all are aware, there is rise in the serum estrogen levels, which may be detrimental to the malignancy part of this patient. So the protocol which we are using is obviously the random start, whether she's follicular phase or luteal phase. And we can start with antagonist 3-4 days and then give her the stimulation, or we can give her progesterone and then later on we can start. But most important is we have to add aromatase inhibitor, that is
yes.
letrozole. And then recently only I have done this a case like this, and I've frozen her oocytes. And in this we gave her letrozole right from the beginning, and after pickup also
Yes,
for
we
another 4-5
continue.
days, or even for 7 days, 10 days
Yes.
we can continue. It is a harmless medicine, and she did fairly well. We did not have any problem, and we could retrieve around 12 mature oocytes,
Yes.
which we have frozen.
Yes.
So this is very important that in these patients we have to add on letrozole even and continue after the pickup.
Correct. Correct. That is.
I
the point.
think
Yes.
progesterone should also be given very cautiously because she's ER and PR positive, and
yes.
progesterone is known to increase the risk
Yes.
also. So
Minimum
yes,
dose
I
we
think
can-
we should be very cautious in that. And letrozole, of course,
Letrozole, yes. So this was yes. Yes, later
In
on.
that case, what will be the option?
I think cryopreservation before.
Before.
Then later on she can have.
So in that case, I just want to know, can you preserve ovary as such?
Ovarian
tissue. I
tissue.
mean ovarian
Yes.
tissue.
Yeah,
means
this-
ovarian
yes,
tissue.
That's what.
Experimental stage only.
Yeah, that's
That's
because
what
in
we
that
had
case you don't
discussed in
require
the
stimulation and all these things because she's hormone positive, right?
Yeah.
So any type of stimulation
Yes, yes.
is really dangerous to her. So in that case, only ovarian tissue preservation, that's under study still.
Yes,
Yeah.
yes,
But I
that
think
is
that's it.
understood.
And because she may require prophylactic oophorectomy also.
So later on,
Later on, she
have
can undergo. Yes.
she can have prophylactic oophorectomy, but before that we have to do tissue
Vitrification of the
preservation
oocytes.
for fertility preservation.
Yes. So we can. Ovarian can be done. Yeah, can be done, but still, as it is experimental stage, though the experimental label has been removed by ASRM, but it is practically not that easier
Ma'am, actually, in India, we have yet to have any child born after
ovarian preservation.
because it is
Yes.
still in the experimental phase.
Hmm.
That is the main problem. They'll, in fact, we don't even if a fertility center, now we have the new ART law.
Correct.
So since
that is
June 2022, it has been gazetted. So there are multiple issues in that. Like previously, donor egg we used to advise. Now that is a big issue now. We have yet to have anything. Then second part is the surrogacy. It is
Yes.
banned from January 25th this year.
Yes. So
we
that
are
is
facing
also.
big problems in these patients.
In where in BRCA,
Actually,
in
Yes, that is.
hormone positive breast cancers, where we do prophylactic oophorectomy. If she is an infertile patient and she and her ovaries can be kept till she completes her family, and
Yes,
then
and
also
then-
we can remove the ovaries.
Yes. So,
So
that is
she's-
also the option.
Sorry? Even if she comes out to be BRCA positive and her ovaries are normal, and we are doing, she's already 32. She's already 32, so we can preserve her oocyte preservation, and then we can remove her ovaries there and then.
So not all BRCA positive are going to develop COV. That's not 100%.
Breast cancer
Breast cancer.
risk reduction.
Prophylactic can be after
Yeah.
completing the family.
And I think with tamoxifen and all these, I think you are a better person to tell about that. So.
Okay. Yeah. So here basically what I wanted to discuss is the same stimulation protocol. So we have the GnRH antagonist. So so this gives basically very less minimal chances of the ovarian hyperstimulation, because that is also one of the deadly complications that we don't want in this patient. And yes, what is the different in the stimulation because of the cancer? Because already the HPO axis function has been affected. There is a fertility is already declined because of the malnutrition and the catabolic stage, as we discussed. And again, BRCA mutations, the oocytes will be having danger of a DNA damage. And definitely there might be requirement of the high gonadotropin dosages, which we have to manage. So basically we have to manage the stimulation well, where the estrogen levels will be very minimal. But definitely these protocols, as madam rightly said, it will not affect the oocyte quality or the number as compared to the conventional stimulation protocol. So this gives a very good result. And another thing just to mention here, because it's a genetic thing, as madam said, so we have to give the genetic counseling, testing. And definitely if the patient if she is going for the embryo preservation, if the genetic testing found out to be positive, we can go for the PGD, that is pre-implantation genetic diagnosis. So I think,
PGD
yes,
is freely available.
yes, available. We can definitely do in such a cases.
Yes, we can offer them this and
Yes.
counsel them.
So that is also, so they will not that will not go in the future generation, that is. And as we discussed, so after completion of that, she can undergo risk reducing BSO. And of course now these disease modifying agents like trastuzumab or pertuzumab, they are contraindicated in the pregnancy. So during that time, contraception to be advised. And also there has to be a washout period after the tamoxifen. That is also very important. Of course, everyone knows that. And so basically, depending upon the size of the mass, again, breast conservative surgeries to be advised, that to retain the ability to the breastfeed. So these were the points. We'll move on to the next. So here it is like 29-year-old. So it's like she had a history of the repetitive chest pain, and there was a mediastinal mass. So basically it turned out to be primary mediastinal B-cell lymphoma. I know. So basically, again, here to point out what is the urgency of the treatment. Again, it's a hematological cancer. So yeah.
Again, it's an emergency, and we know
Yes.
that this is B-cell lymphoma. So both chemo and radiation patients
Will
going to
be
need.
required. Yes.
So again, fertility preservation has to be, counseling has to be started. The
Yes, so
procedure has to
that
be
point
started.
now we agree upon at the diagnosis, it is important. So this was just to put a light, as madam already discussed in the previous case, that there are different protocols which are random start. So that was initially when we were also starting this and talking to oncologists, not gynae oncologists, routine oncologists. So they had, so we have to wait till the menstrual cycle, then it will be so much delayed. You might take 15 days, 20 days. So practically it is not. So we can start it at any time, which is a late follicular phase, even even the luteal phase without affecting any outcome. So in these patients, we also have the option of something called IVM. This is practically done in vitro maturation, where we retrieve the oocytes little early and we freeze them at an immature stage. Later on, in vitro maturation can be provided. But of course, we need to take precautions here, because hematological malignancies will have like bleeding, thromboembolisms, risks of infection, and other anesthesia complications.
Yes, a
So,
complete
yes.
medical evaluation, including PT-INR, is
Yes,
very
that is very important. Correct. So that we require a team. So we should have like a backup, everything, and then these patients can undergo the pickup and further things. Now, this
pregnancy rate comparable with IVM?
Yes, it is. It is little reduced. Little reduced. Yes, not exactly medias, but available. So, but not reaching as per these things. Yes, role of the lab, embryology, and the yes. So that is basically a complete. When we talk about the fertility now team, it is inclusive of the clinician and the embryologist, because almost it is 50-50%. So 50% when we work on the endocrinology and the procedures, they work 50% in the lab, and that gives the final outcome. So definitely the both has to be, it's a equal almost. So that is there.
But I think IVM is going to pick up in this particular these particular malignancies, because it practically reduces the chances of
even the hyperstimulation, then metastasis also, and another thing is time duration is less.
Exactly.
Yes, so that is
need
there. 5-6 days it is enough, and still we get a almost comparable outcome. Okay, so this is also interesting case. So 32-year-old, and she already has one child, and history of the right salpingo-oophorectomy done for stage 1A borderline ovarian tumor in the past, and then now left adnexal mass. I think I'll tell Dr. Anu to discuss about it.
So in borderline ovarian tumors, normally if it's bilateral masses, I mean, one has already been removed, you said.
Yes.
So we can go for a cystectomy, but the results are not as good, as the outcome is not as good as an oophorectomy. So she has completed her family. She is a 32-year-old lady. We can counsel her and go ahead with a oophorectomy also.
Yes,
for her.
but ma'am, one child, so we just have to ask.
Yeah, so that's a counseling part that has to be done. And we have to tell her that we can do a cystectomy if possible, depending on the imaging and so many other factors. And if that is possible, and if she is ready to take the risk for future, then we can go ahead with a cystectomy. Otherwise, I personally would prefer completion surgery.
Even I would not suggest any fertility preservation in this patient.
Ideally, yes.
One child is more than enough, I think.
So better just to give the options, but then more counseling towards completion of the surgery.
Definitely that is counseling, and
that plays an important
proper consent, and all legal advice and all future results have to be told her in detail.
Correct. Yes. So I'll go ahead because much less time. Okay, so I think I'll skip this, but I just wanted, so as the more challenges in the survivorship in these patients when it was not offered, fertility treatment was not offered. So because they have more concerns in the fertility issues and desire to have a family. So majority of these patients initially, when they were not offered, they had a regret. And that was a very, this thing. So I just have to make it a point that receiving a specialized counseling about the reproductive loss and the fertility preservation is associated with a less regret and greater quality of life for the cancer survivor. So that was one point to make. And here I think we will discuss what are the ethical and the legal aspects.
I think you can just enumerate these because we don't have a legal expert in the panel.
So
just,
we can just,
Namita, you want to make
if
a point?
madam wants to make some.
wanted to say that every onco-surgeon and onco-physician should actually, in their consent forms, should actually have an informed consent point that they were given an option of fertility preservation, because we are getting patients who say that they were never given an option.
Ma'am.
That's the most essential aspect. And for that, you need to have an infertility specialist and a gynae oncologist in the team of oncofertility.
So
unless that is done, it is not going to be done.
that I'll come to it, that there was no option given and she had to take a donor egg, which was a very difficult for her. So those are the things. So that will come to it. One is a proper documentation. One is we, as now this generation of doctors, we have to decide now. We have to take initiative to form the guidelines actually in India and the referral pathways which are feasible. The center has to be there, and we'll discuss the key points. So I'll just enumerate, I think last just 5 minutes. So basically, ethical concerns are, it has to be given to whom? So it has to be offered to each and every patient where there is a curative intent, definitely. And now again, financial consideration will come to this now, because still the insurances are not covering the fertility part of it. So we are still battling with the insurance companies.
Fertility as such is
Not covered overall, because they consider this is non-essential part. This is a non-essential treatment.
Considered as a disease or pathology.
Yes,
But then fertility clinics are flourishing, mushrooming like.
But ma'am, there is no insurance cover. There is no insurance cover.
With this new ART
law again,
now
it is
people are shutting
Less money probably.
Yes, yes. And the thing is, here again, insurances are covering disabilities caused by the cancer, but they are still not taking into consideration that infertility is one of the disability which is caused by the cancer and its treatment. So there is the battle that is still going on. NGOs also should support this. Like we have an onco-fertility unit. So we do it at very, very minimal cost. And we also give some funds from the patients, from the hospital, some NGOs, and some funds from the patient. So that is
really
one.
nice.
Now
Yes.
the laws have come that they have to, we have to renew the
Preservations
every
also.
10 years. So
Yes.
then it is not expensive at all.
Yes,
It is
yes.
only the first time
The usual cost of the stimulation and all. So we are trying to make it very easy.
Yes, now
Because
it is very easy.
yes, more concern at the time of diagnosis, they have to go for whole cancer treatment, which is also costing a lot, and at the same time this burden. So it becomes difficult for them to take this decision. So we are trying to help it out. Again, dispute over the frozen gametes, embryos, and here it is the actual requirement of the good documentation. As madam said, the counseling was offered, whether they have taken it, not taken it, denied it. And when we freeze them, then we take, and after the death, what is to be done? So there's something called posthumous reproduction. Sometimes the patient, that is also one of the ethical this thing. If they have given the consent themselves that the gametes can be used by the spouse, then only it can be used. Parents cannot decide that, it has to be used later on. That is the only patient's decision. That is very, very important. So because sometimes
Another thing I would like to highlight now, since the law has become gazetted,
Yes.
we have to take the posthumous consent
beforehand.
starting the procedure.
Yes, it is a beforehand. At the time of the freezing, because most of the time, sorry, ma'am. Yes, you have been.
Divorces are nowadays
Yes.
very common. So if you
That
freeze
is
the
also
embryo and
very-
they are separated, then what to do?
What to do
Or
with the embryos?
Like I had one patient in whom he was supposed to come for sperm preservation. But then during chemotherapy, they decided not to go. And during chemotherapy, went into acute kidney failure. and
Yes.
expired.
And if, yes.
Then the wife came to me that, did you freeze the sperm? Because I want to carry the baby because we have so much of property on the in-laws side.
Yeah, so
there are
that is
lots of
very
social
problem.
So I think all
Social
the more
issues.
that we should have legal
Documentation,
advice.
yes.
Yeah.
So we need a legal team also.
Yeah, unmarried can give.
Parents will give.
Parents will give,
parents
and if he or she is an adult.
Yeah.
Yeah.
Later on.
If ideally for the unmarried, it has to be, they will give in the consent, whether it will be used by my spouse. Actually, parents cannot decide on the behalf of, that's what, unmarried.
To be spouse.
To be spouse, if known, actually the parents cannot decide. We had one case where the hematological malignancy, boy was 18 years, so adult to give the consent. He has, he has ticked on the consent that not to be used, but parents were requesting that if you have a sample, then we will, use it and all that. So with the legal team and all, we had the counseling sessions. We showed no, it is the person's choice. What is to be, the parents cannot decide.
Spouse's choice.
Person's choice.
Person's choice. The
Whether
patient's
gametes
choice.
can be used or not. Yes, but there also the consent also, but there also parents, that is not, if the only for married patients they can decide whether it can be used by my
But
spouse.
she is asking for unmarried
So
girl.
married cannot. No? Then
So
they
if less
cannot.
than 18, parents have to give the consent.
What I
Yes.
said, parents
Because
have to.
then we face this issue that aap bachche ko mat batana, but then we
But
have
we
to
have to tell.
explain them.
We have to
Because
explain.
now with social media,
But I think,
children are quite mature.
yeah, and I think
They
there is
know
one
everything,
point,
they
if I am
understand.
not wrong, that parents have to, the consent of both is
Both.
essential. Parents' consent and,
And
the
child's
child's
consent.
consent.
That
If
is
the child says no, you
Then
cannot
you
go
cannot.
ahead. Whatever
Still,
it
ma'am.
is, she
With
has,
the
child
pediatric
has to.
counselors.
Yeah.
the social
Yes, with the
platform, they are
pediatric
very,
counselors.
mature to understand all these things.
So in that case, consent of both is.
That is, a child's consent is known as assent if it is a less than 18 years, and that has to be documented, and with the pediatric counselors. So yes, we had that posthumous reproduction, so where, but this was a consent which was given. So the couple were undergoing, so first IVF cycle was failed, but the sperm was frozen, and the consent was given that if in case of death or anything happens, spouse can use. So with that consent and with the legal again affidavit and all that, we can use. So here it matters about a documentation.
Consent at the first,
First go itself. We cannot take a consent which is later on.
because
And ideally,
nowadays, since this law has come, I think we all are taking this consent.
before, yes.
For any patient, irrespective of the
And especially, ma'am, here we prefer video consents also, because that is very safe at the time, and everything has been noted and proper counseling has been recorded.
Other than the signatures, the thumb impression
is also important. Yes. So those are certain.
Actually, legal and all aspects are to be considered. It's not so easy.
Yes,
Yes,
that
we
has
have
to be
save
saved.
till 21
Has to
years
be saved.
ideally.
Yes.
And
10
for
years, law says 10 years.
law says 10, we keep it as we have made this in
We will
21.
keep till
But
we are
ma'am,
alive.
But ma'am, for onco fertility, because it's a
Yes.
long-term
What
freezing.
happens if the treating doctor is no more there, like me, aged? So then what happens? What do you do?
The center has unanswered questions. So yeah, so basically it's a joint project of the couple. So definitely it is big this thing, but with the documentation, so we do that. We have done one such a case and that came out well. And as I was telling, there was one where she was a doctor, pathologist by a profession, and at the age of 26 years there was a breast cancer, but the counseling was not provided. So she had a lot of problems. Her AMH was very low, and she went still with a self cycle, but there was a miscarriage. But taking a donor again was a very this thing. So it is very important to provide such a counseling. So I'll just put one last thing. What is our goal and how we can have the ideal onco fertility setup. So there should not be delay in the appointments. So it should be as accessible, as early as accessible to the patient. So there has to be good time to time coordination with the fertility and oncology team. And of course, as we use customized stimulation protocols, then good advanced cryopreservation unit, so good embryologist and lab, and basic to advanced fertility treatment facilities under one roof, so that patient should not have to go for one center to other center so many times. And this availability should be like super specialty team should be available 24/7 as no delays, and genetic testing, genetic counselings and everything to be available. So this is ideal model of care which is given by ESHRE. So where a complete circle like oncology team, fertility team doing the fertility preservation, going back to the onco team, and again coming back to fertility team for pregnancy. So actually this is the complete circle. And hopefully as we are doing this onco fertility discussions and all, we should come up with such a consortium in India. Actually that is really urgent unmet need what we feel, and we have started doing that work, but it requires at a mass level, I guess. So
yes, I think it's sad that we have such sparse attendance, but this is a very, very important aspect of oncology. And with more and more women planning late pregnancies and more cancers being diagnosed in younger age, I think this is a real-time issue.
Important.
And we need very, very consolidated and focused
Also,
management.
I think public awareness is
more.
Yes.
to do some activities for the general public.
General
Make
public
them
also.
aware of these options.
Yes.
I think we had once talked about it.
Yes, yes.
So thank you
COVID,
so
you
much.
know it.
Yeah, cool. So thank you so much
thank
for
you
very
much.
nice
It was a
discussion.
very nice panel.
And just to make yeah, please. On.
I'm Dr. Santosh, medical oncologist from Hyderabad. I really enjoyed the session, learned a lot of things. In oncology meet, I especially wanted to attend, although this was the last, I came here to attend this.
Thank you.
So I felt very
Thank you
useful.
so much. Thank you.
So I just want to tell our oncologist perspective. I think
Yes.
one person currently passed, one oncologist should have been there in the panel.
Yeah.
So what
Yes.
my thinking whenever I send to oncofertility is, how is the malignancy curable?
Correct.
Highly curable, how urgency is the treatment? These are the two things. First, I have to decide that, yes, this patient deserves proper oncofertility.
Correct.
So first, doctor has to be convinced. That
Yes.
depends on the curability of malignancy and how aggressive I have to start the treatment.
Correct.
Second point is, after I decide, when I counsel the patient, almost, madam, in my practice, only 5 to 6% would turn up to oncofertility. After turning up, then the duration and all, they will...
Hardly one will materialize.
Yes,
actually.
madam. It's very difficult.
Practically.
So that is one aspect where,
Especially females, females.
Yes.
For men, it's not so difficult because
Yes, especially
for
females.
females, it's an invasive procedure.
Yes. Yes.
I think partly that is also because there is so much of fear for cancer even now.
Yes.
The word cancer spells death for them. So they do not believe that they have to focus on any other issue. It's just like cancer ka treatment ho jaye kaise bhi. So there are lots of other holistic things that have to come into picture. And you're very right that we have to make this a more concentrated effort. You know?
As we have discussed the second case, Hodgkin's lymphoma, the cure rate is more than 95%.
Correct.
That is the ideal patient for
To go for it. Yes.
the next case, acute myeloid leukemia. In that case, I would not myself push towards
Much.
that, might entertain more legal troubles also, because the survival in acute leukemias is very, very minimal,
Yes.
and they have a lot of platelet dysfunction and
Correct.
all these things. So
Yes.
that case, we would not likely to push ahead, but Hodgkin's lymphoma and young breast cancers, we would push.
Definitely.
This is one aspect. The second aspect is that was briefly touched, especially those who are BRCA positives. Those patients, whenever we push for fertility preservation, they would think about the next generation. Suppose my egg would have this.
Same.
So So
Yeah.
I just have a doubt, the pre-implantation diagnostic, how widely is it available, madam?
That's very
It's-
routinely
Okay. So we'll test the embryo whether it has the mutation or not.
and very routinely available, very routinely done. And nowadays it has, I mean, it is not a new procedure at all. So yes.
And one more thing was, whenever I counsel the family, I had a patient who has BRCA positive.
Mhm.
She's around 50 years, has 3 daughters.
Hmm.
I've advised that high chance of BRCA penetrance,
Correct.
you should have to test in your 3 daughters. She gave me, शादी के बाद कर लेते. पहले शादी होने दो सर, जो भी है बाद में कर लेते.
Social
Cancer is a stigma. Even
Yes.
hereditary is a stigma.
Stigma.
So
And
we have to overcome that first. Yes.
I had a patient came yesterday. 3 board members already are affected in the family. Then also she got married.
That is the other.
Marriage
That is
is
a social stigma. Yes.
How early can we do, madam, if I send a lady, matlab, for this one antagonist? How early you can?
It is an immediate start. Now we don't want to wait for the periods at all.
Suppose I send a patient for
I can start
Same
off
day.
later.
We can start same day
Same
because
day.
in such a, like in our unit, it is in-house, everything in-house lab. When she comes, we decide, we do the lab, we get report in 1 hour, AMH and hormonal profile. We see
LHG2 we get it
LHG2,
done.
FSH, and immediate same day also we can start.
Start the-
Minimal
we
like
do a
9
baseline
days.
scan
Yes.
ourselves, and then we immediately start the program.
9 to 8
9
days
to
or
10
9 to 10
maximum,
maximum.
10
Yes.
10 days.
10 days.
So after collection, how early we can start the chemotherapy? Because
Immediate.
platelets tend to fall after our chemotherapy.
Within a week, you can
Week next.
I mean, actually, within a week also, but immediately as such, transvaginal oocyte retrieval, it's not like a big surgery. It's just one prick. So even immediately, yeah, there is no surgical as such, you need not
So
wait.
maybe by 2 weeks we can.
Yes. Maximum 2 weeks from your
Maximum.
side. Yes.
Thank you very much.
Thank you. So thank you so much.
Thank you.
Yes. And for the oncologist, we had this onco fertility manual, which we had published in 2020. Yes, yes, onco. So you can just have a look. That is mainly for the clinicians that we had made from our department as an effort. That book is available.
You share it.
Definitely, I'll share the link on the group, definitely. And thank you so much for being a
Thank you, Dr. Snehal. As a pathologist, I was an outlier, but I understood each and everything. Thank you.
Thank you all faculty members. Thank you, Dr. Sandeep Jasuja sir, for this nice session. Thank you all the panelists. Thank you all esteemed faculty for attending this session. Thank you very much.
Yes. Thank you for Okay, thanks. Nice meeting you. Bye. But we have all under one. Started